leave me high and dry. Oh, well, I don't wanna jinx it, baby, and twist myself at the spine. Don't wanna overthink it, baby. It's just twist your body and mine. Baby, you give me ice and fire. You're giving me wind and rain. Baby, you give me ice and fire. You're giving me wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby, and twist myself at the spine. Don't wanna overthink it, baby. It's just twist your body and mine. Baby, you give me ice and fire. You're giving me wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, but I don't wanna jinx it, baby. Let's not get ahead of my time. Oh, but I don't wanna miss you, baby. So I stand up and speak my mind. Oh, baby, you give me ice and fire. You're chilling wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, 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 my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby, and twist myself at the spine. Don't wanna overthink it, baby. It's just twist your body and mine. Baby, you give me ice and fire. You're giving me wind and rain. You're some kind of butterfly. Baby, you give me midnight oil. You whip up my appetite. Don't leave me here high and dry. Oh, but I don't wanna jinx it, baby. Let's not get ahead of my time. Oh, but I don't wanna miss you, baby. So I stand up and speak my mind. Oh. Baby, you give me ice and fire. You're chilling wind and rain. You're some kind of butterfly. Baby, you give me midnight oil. You whip up my appetite. Don't leave me here high and dry. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight oil. You whip up my appetite. Don't leave me here high and dry. Oh, 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 my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby.
More than that, what I like is Sir is very friendly and generous, very easy to mingle with him. And same with Shreyas, always smiling. So from the time I met him in the state conference for the first time, he's a very easy to mingle person. So now, yesterday they did a very good dissection, showed various approaches with intact canal wall technique. So today we would do some extended approaches, and this temporal bone, as you said, is like a gold mine. There's so many things that you can do in this temporal bone, which I'm sure if you, in due course of time, people will be like amazed. There's so much to do in the temporal bone. So you don't need always a head or a, fresh cut head. So we can always do most of the approaches, even practice skull base approaches using the temporal bone. So I just wanted to orient. So we will show the ossiculoplasty and grafting in the meanwhile after some orientation. So I just want to orient what has been done yesterday. So this is probably a diploid type of a yeah, low power, sir. This is seen, sir. Okay. Yeah, it's always that is also a good idea, sir, which sir told. Usually, when you are doing a wider approach, so the first point is when you're doing a wider approach, like say a translab approach or even infratemporal fossa, when you're drilling the bone, outer bone, the cortical bone, it's always better to start with the lowest magnification. The whole idea is to have the whole field in your view. For example, here I can see the zygoma and the root of zygoma. I'm seeing the superior, the squamous part of the temporal bone, the tip of the mastoid is seen here, the exnotic canal is seen here. So that is one thing. So magnification, when a wide approach or skull base approach, or when you're drilling the mastoid also, people asked yesterday why we should use microscope. Definitely microscope is, I mean it is to be used, of course. So usually sometimes, yes, if when we're in a hurry, we just drill and open the till the antrum as soon as we enter the antrum, but the further drilling always we do with the microscope. But when you start drilling the cortical bone, keep it in low magnification to start with. So that is what you need. Don't keep a high magnification, then that will disorient you a bit. So that is one thing. Now other thing is that, see, this is the, I just want to reorient the structures. This is the dural plate here. There is a, because of this dry bone, in this bone, you see that the dura is given way here. This is where the sigmoid sinus should come, but I want to drill further. This is the tip of the mastoid. This is the tip of the mastoid. And as discussed yesterday, the retrotympanum area, so this is the exnotic canal which has been thinned out, and you've been shown cochleostomy and cochleostomy, I think video went, cochleostomy and other approaches yesterday. You can see that handle of malice is there here, that the head of the malice being nipped off to go to the attic, and the stapes is still here. I need to tilt this a bit. The stapes suprastructure is still there, so that it's okay, sir. No, yeah, yeah, because yeah. So the stapes for me it's good, sir. Here actually, the stape. Yeah, I'm using the hand to lift that this thing to tilt. Yeah. So yeah. So this is the stapes suprastructure which is there. So that is one of the important things. So whenever there is no stapes suprastructure, somebody was asking about ossiculoplasty yesterday. So I spent some time with Professor Uttenbrink in Cologne as a ISOCON fellow. So whenever there is no stapes superstructure, whatever you do, the hearing results will not be always great. So it is the presence of stapes superstructure and a mobile stapes, you can give good hearing results even when you do a type 3. But we do get a lot of situations when the suprastructure is eroded, especially in retraction of the tympanic membrane, and then adhesive otitis medias and the cholesteatomas, and sometimes even in chronic ears with granulation, I see that stapes suprastructure is eroded. One thing I want to bring to your notice: whenever there is an unstable foot plate, that becomes the next ball game. So when I was in Germany, I saw this Professor Uttenbrink using the Omega connector. He had done something like an ohm prosthesis to put on an unstable foot plate. He puts that, and almost all surgeries of this, the first six, after 6 months, they do a revision to just check the ossicular state. No, yeah, it is little unstable to reconstruct, sir, putting any prosthesis. because they usually use the Kurz processes. Yeah, hypermobile, or it is like subluxed a bit, and they don't want to do it in one sitting. So I saw professor putting an omega connector, which is basically like a home shaped with like basically this stapy suprastructure, like a cap to this area. And 6 months later they always have this principle of every year with cholesteatoma or whatever they explore after 6 months. That's a mandatory second look they do. So second look they do a ossicular reconstruction. So this is the principle. I'm just telling all this just to orient. So we have various situations, like generally you have a malleus and your stapes is present. Most often you see that in a diseased mastoid, especially in even in a chronic ear with granulation, maybe the tip of the incus, the long process of the incus is eroded. So that is when, or sometimes there is an additus block, the long process of the incus is eroded, partly loosely connected to the stapes. You can easily remove the incus and then you can do a type 2. I think we'll show of the ossiculoplasty. So we are ready with this thing. I think you are seeing the tossicle. We are using the Darlaki forceps. Is it seen? You can also tell about type 1, type 2 osteoplasty. Yeah. So normally, yeah. So for me, type 1, I mean, I call it tympanoplasty is when all the ossicles are intact, and then you just check the mobility of the ossicles, and you just check the round window reflex. Type 2 is what we do occasionally in situations like this. Yesterday, when we removed a small diamond, but 2 millimeter, where we removed the incus, we can use the same auto incus. It's an auto incus graft. The other thing I want to tell you is that the incus, unless it is really embedded in cholesteatoma, there are situations when even if the incus you are removed, you cannot use the incus. So it is very important. Sometimes even if you don't have a Darlaki forceps, you can use the artery forceps and you can stabilize, but you should be very careful. Some people do underwater drilling of the ossicle also. This is slightly pulling. Can you just push? Yeah. Now it's okay, sir. Yeah. Then now it's okay, sir. Yeah. So this is the incus. So we are seeing with the Darlaki ossicle holding forceps. My tool. Yeah. Now you can hear me, sir. Hello. Yeah, it's going off in between. Hello. Okay, so maybe the voice is louder. So this is the Darlaki ossicle holding forceps. I think I don't know whether the madam who asked me about this ossiculoplasty yesterday, is she there in the hall? Yeah, she's there. So this is the long process. So you can do various methods. So commonly there is no one. I basically I just show you what I do. This is the auto incus. I've seen it being used in various forms. So keep it very stable. Otherwise it is going to fly in no time. So we'll tighten this. Yeah, you were also telling about the type 2. Yeah, type 2 is basically when I use the incus, that is I call type 2 tympanoplasty. Type 3 is when you have the stapes suprastructure. Either I place a vertical cartilage strut or I place a horizontal like a shield cartilage. I call it as a type 3 when the malleus and even if malleus is present or not present, directly on the stapes, what you call as a meringostapedopexy. Then when there is no stapes suprastructure, we can put the ossicle or the graft directly on the foot plate. That also I encounter often, actually more than type 2. That is what I encounter often because of the disease ears which we operate, and in such case I call it type 3b. Beyond that I have not done. So that is type 3b. So these are the common situations. So what I am doing is, I'm just, if you're seeing there, I am drilling the long process of the incus. So I've drilled the long process of the incus. So you can just do. I've also seen this. I'll show you one more way how this incus is used. So I've drilled the long process of the incus, and then I'll make a facet for the, see here also you can do it in two ways. You can do multiple, something like a lever mechanism you can do. I'm just drilling to make a notch to anchor this under the malleus. You're seeing this? Yeah. Anchor this under the malleus. Only thing is you'll have to keep the ossicle stable. I'm not going to spend too much time in this because we have a lot to do. Okay, maybe you can adjust the length a bit. Okay. Yeah, this one. And then we can even make this, can have smaller this thing. See how you do and arrange, it's finally, it is your creativity. You just have to keep the malleus and the stapes in contact. Stapes in contact. So I'll just demonstrate a simple way how I keep it in contact. Okay. Can you give me a smaller one? Maybe 1 millimeter or a 0.8 one. This one is okay. This is fine. So once you're done a notch. You've done a notch for the malleus. I'll do a small facet for the head of the stapes. Small facet for the head of the stapes. With a smaller one is that? Yeah. Do a small facet for the stapes. Yeah. Here, sir. With this. I'm sure sir has been doing this same thing. So you do it anything different, sir? Yes. So give me the suction just to clean up this. So I do a facet for this and I have a notch. Okay. So now, yeah. Yeah, you can. I mean, sir, you can do it in any place. I mean, just you just have to put it in orient. I'm going to put it like this and put it underneath. But you can also do like multiple lever, like you have those elevations like bunts in the road. So I'll just can you give me that sickle holding the force? Yes, sir. Can you remove the sickle? Yes, sir. Yes. The like goes and orient us. Yes, sir. So that we will know where was the knot and where was the sickle made for the steady side. Yes. You have forceps, the long forceps. Sir, see, this is where I think, can you see? Give me a sickle knife or something, please. A straight pick. Keep in state is orientation. State is anatomical. Yeah. Anatomical position. Like now it is in the right bone, isn't it? Yes, the right side. State is side. Keep in that orientation. Yeah. Then we will know what have you drilled. So actually, yeah. I've already drilled the long process. Okay. So I've drilled the long process. I've kept the short process. A little bit I've just modified the short process. Yeah. So this was like this actually. Like this. I've drilled the long process. Yeah. Now, I mean, I've just made one notch for the malleus here. Malleus. Under the malleus. Usually you put under the neck of the malleus. And one facet for the stapes. You can see here. I think, is it seen here? No, sir. This is a notch here. Facet is in the base of that. Facet is in the base here. So now I'll put that here. I'll put that on the. See, you have to of course adjust it. Can you give me a? Can you hold like this, please? I'm not able to. Yeah. Give a sickle knife. Small section coding. Micro section coding. Sickle knife. Yeah. So usually, see, this is ossicle again. It will slip. So it's very important for you to take. I always take it with the suction. I take it to the suction. Again, it's little. You have to adjust the shape. So what you do, see here, it is nicely sitting. Can you see this, sir? Yeah. You are able to see? Give me 18 or 20 here. So this is, in fact, the auto inkers, not many have done, but whenever I have done, the results are extremely good. As good as a type 1 tympanoplasty, the hearing results. Because yeah. This is ossicle awesome. Okay. This here, malleus is an ossicle and tapetus is an ossicle. When ossicle to ossicle reconstruction you do,
then you are actually establishing the nature's ossicular liver ratio. Okay. So whatever it is there. So see, this is the assembly I've done now. Yeah. I put it on the stay piece. Look here, the spring movement I'm seeing. Basically, I think I drilled a little bit more here. Otherwise, it will come in contact with the malleus. Yeah. So it will come here. I just want to show you because we will not waste much time. So anyhow, we are going to put a graft also here. So this is the assembly and it is going to give very good result. I mean, so I've also seen when there is no foot plate in the suprastructure. So I'm just going to remove this. I just want to show you one more thing. I've seen Professor Mario Sanna a couple of times, even in a congenital colostoma in a child. So when there is no suprastructure, he doesn't like to use any prosthesis. I've never seen him using any prosthesis. Yeah, he never uses. Of course, the ossiculoplasties are not often in group O because the kind of cases are different there. So, but he never uses any processes, cartilage or so just place the see on the foot plate. Just place the incus like this. Okay. Even if I have to place this, so basically what like Anand sir is to tell, we should do something called as a water test. So you put it here. See, I can see that spring movement. I'm able to feel it here. Yeah. So this you can just put it straightly on the foot plate. Give me water irrigation. Clear? So you always check the assembly. So you just irrigate and just do a irrigation and just check whether it is falling off. So this is one more thing that you do. Okay. So head shake test. Okay, sir. Okay. 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 Yeah. Sickle knife. So I think this at least the type 2 is clear. And if you have an incus like this, yeah, if you have an incus like this, I mean, it is a pleasure to have. I mean, you don't need. I don't think you need any prosthesis. So in fact, I also don't use any of this torp or prod prosthesis. Once or twice I used the course earlier. It's costly, but with the cartilage and this thing, most of it is managed. Okay. Type 3. Yeah. Because type 3 is from AP superstructure to the GOT panicum. Yeah. So then there is loss of ossicular liver ratio. Okay. And here ossicle to ossicle reconstruction. So it is something like nature's ossicular liver ratio is established. Yeah. Slightly the vision is not there, so I'll just keep it here. Test is like after the assembly. Okay. After keeping the graft, yes, ossicular graft on the stapy superstructure or on the superstructure, then shake the head of it. Okay, then you give me that silver foil, boss. See if it falls off. If it doesn't fall off, then it is quite stable. And there are no muscular forces inside. See this? This is a very good. See, like right now. Whatever you have like that. See, this is a. So I can feel the spring movement. I think the audience is able to appreciate. I mean, this is more than enough. Can you give me a silver foil here? That this thing. So just because I wanted, somebody asked me. Normally I do, sir. I always do. No, I cut one smaller one here. I do a 360. Most of my cases, I do a 360-degree elevation of the skin and the remnant drum. Most of my cases, but I can always change. And I also do what you call as no, it's here. I also do sometime many times I end up doing 360-degree canalplasty. So that gives me, and for me the grafting becomes very easy after that. So, but if at all I don't do it, I always make an anterior window. I'm just showing to the audience that somebody again how to do grafting. So I could get this. This is the blade, silver foil from the blade. It is not pliable like your graft, so it will not be easy. Just give me a scissor. So I'll just show you. You can just tuck it. So even if you can retrograde, elevate and tuck it, I think as long as you place adequate amount of gel foam, say for example, you have this anterior remnant. So usually give me a round knife or a round knife, please. Round knife. Yeah. Yeah. So what I do is, one is this round knife was. What I do is, I do an anterior window technique. So I make an incision here. You can see. Yeah, this is to be tilted a bit like, yeah. So I do anterior, not centered, sir. So yeah, now. Yes. So I don't like to, honestly, I even this I thanks to my mentor, to my lend, I don't like to make too much canal incisions. In fact, I hate to do canal incisions, and I always tend to avoid. So this is little pliable. So what I do is I raise this, make an incision here. Give me a sickle knife or something like that. Yeah, I make you should know how to separate the mucosa. This is a mucosa here. So this is little pliable. So bear with us. So I cut the mucosa here.
I cut the mucosa here. This is not same like how we get in the real life. So I cut the mucosa here. Peel off. So I'll just show it like this. So then I'll give me the graph material. So or else you can do, in case you have a good remnant drum, and subtotal perforations are actually easy to operate. So that makes the whole grafting easy. So except the small, only the small anterior perforations are the ones. So or else you do retrograde elevation. You should know where is the mucosa, where is the annulus, and you should know that the mucosa should be under the graft. You can elevate like this, and then you can give me the graft material. So I will just show. I don't think it is easily. I always do double breasting of the malleus. So cut which side? Give me scissor.
There's a question here.
Yeah.
Which cartilage you use? Tracheal cartilage or bronchial cartilage?
Sir, I give me small scissor. I use the conchal cartilage only, sir. I know people advise the foot plate cartilage from the septal cartilage, but generally when I'm doing ear surgery, easier to expose the conchal cartilage. But if you can have a cartilage bank and preserve the septal cartilage, I'm not septal cartilage is also good. But tracheal cartilage or perichondrium, I just used to do transcanal meringoplasties or tympanoplasties, not for doing ossiculoplasty. I use a little bit of a conchal floor cartilage, and which is pretty tough. I take a solid block and then I do. So as I said, I'm not going to do, let's not waste time. There's a graph forceps. Yeah, foil will be difficult. Usually I use a graph forceps. I don't, yeah, always go under the malleus. Generally I go under the malleus, but I'm not going to do that here now. So just place the graft. Make sure that the graft is lining all around the canal. So all around it is lining the canal, and this is not pliable at all. Otherwise it would have been easy. And just line this, and then that is how you finish the tympanoplasty. Yeah, I pull through the anterior window. If at all I don't do 360-degree elevation. But as I said, most of the times I elevate the whole skin tube, including the remnant drum. And even if there is even if it's a moderate perforation, we would have freshened the margin. And I roll the skin tube here and keep it here. Then I place the graft and roll the skin tube back. This is the toss technique which I learned. And so I don't have any canal incisions at all. So even in so I don't do any posterior canal incision is like very rare. I might do it like if I do 100 cases, maybe I might do in 3 to 5%. That's all. So I don't do posterior canal incision. And for me, by 7th, I usually put a Mirocell pack after doing all that. Very little gel foam in the middle ear, and some gel foam outside, because then we keep a Mirocell. That is, we can always suction on the Mirocell. That is called as a displacement technique. So you can even put Ziplocs, and even canal wall down I do. Even if I obliterate, I put 1 or 2 Mirocells and sterile Mirocells, and I keep, when I call them for the dressing, I suction on the Mirocell. So you will see that usually the Mirocell will be blood stained or something. So that displaces the coagulum, and that actually helps in faster epithelialization. And usually earlier I used to remove the Mirocell by 7th day. Nowadays I cut a small, I standardize it to 10th day. 10th day I remove the Mirocell. In canal wall down, I keep the Mirocell till 15 days. So honestly, with this technique, I have never seen a graft failure of my own. I don't know whether this thing. So and I also do the canal plasty 360-degree. So leaving this, now we'll come back to the skull base. So the lateral other extended approaches with this temporal bone. Any doubts? Yeah. No, we all put earwick, na. Somebody uses. What do you do after packing? Betadine gauze. I mean, gauze is gauze piece. I don't like the gauze fibers. Yeah, Mirocell is way better. Gauze or even the cotton wick and something. You know, I totally hate. I don't put any cotton once I've operated the surgery. I just use a Mirocell. In fact, we can cut one Mirocell if you have a sterile ETO, and you can cut and keep with 1 8 centimeter. You can make 10 packs. You remember there was a ear wick which was coming, that Mirocell like wick. So something like that. So that, yeah, very good. I mean, I think nothing better than that, I feel. If you have Mirocell, nothing like that.
The sequence of procedures you're going to show us now?
So now what I'll do is, I've already oriented. So we'll do a translab first, sir. Because already the labyrinthectomy has done. This is the vestibule.
So basically, the vestibule is like the floor of the vestibule is like the roof of your internal acoustic meatus. Before that, I'll just show you. This is nicely thinned here. So yesterday also I saw in the participants a lot of people, the outer canal wall, they did not saucerize here like this. That actually impedes your angle of vision. So I'm just going to thin this. Okay, so thin this, so just that any angle, even a millimeter of bone which is removed gives you a centimeter of space inside. So again here we'll identify for me important structure. What are the two important? Give me a big section. Structures basically in skull base or when you are doing a transtemporal approach. I mean, see, one should not have. I'll tell you the last 6 weeks, the kind of the last 2-3 weeks, the kind of cases I've operated in otology. I'm convinced that, I mean, it is not necessarily that you will have to go and do an acoustic tumor. It is for various other surgeries, revision mastodectomies, cholesteatomas, and skull base osteomyelitis. Even if it's a TB mastoid, I have a case where I just opened anterior to the carotid. I saw thick cheesy pus. It came as a TB mastoid, and also it had gone into infratemporal fossa anteriorly. So you get various crazy situations. I'll tell you, all these wide exposures will help you in doing surgeries. So right now, I'll just drill because you have a tip of the mastoid. Once you know where is your digastric muscle. So as you said, as you know, the development of the mastoid depends upon the sternocleidomastoid as it is pneumatized so you have a layer of muscles here attached. I wanted to show you one step of amputation of the tip of the mastoid. So that is why I am doing this. See this, you will get the so much cells here. So here you have the sternocleidomastoid. Following sternocleidomastoid, you have one more layer of muscle, splenius capitis, which runs perpendicular. The fibers of the splenius capitis will run perpendicular to the fibers of sternocleidomastoid. And then comes the digastric. In fact, you have many other layers, other 2 or 3 layers of muscles, which I'll not get into it because they're extremely useful, especially if you want to do something called as extreme lateral resection of the temporal bone. So that's not, let's not discuss about that. But I just want to tell you that the digastric will be attached here in the digastric ridge here, and then the sternocleidomastoid. So this is a commonly done. Yesterday, somebody was telling me, show the approaches, show what like is useful for us to do the case, not just drill and the anatomy. So this is one thing. See, now I'm drilling here, plus same thing. Better cutting ಇದೆ ಸ್ವಲ್ಪ ಬ್ಲಂಟ್ ಆಗಿದೆ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಕಟ್ಟಿಂಗ್ ಇರೋದು ಕೊಡಿ ಇದಾ. So I'm going to saucerize. Irrigate, please. More irrigation. Keep the. So these are fast approaches. You see with this thing, I'm saucerizing the edge. Very hard bone actually. Now I know when players were filling yesterday. Irrigate on this thing. Please hold the temple bone. Unusually hard. Yes, sir. So this amputation, I routinely practice in this skull base osteomyelitis cases. Yeah, malignant otitis externa. I practice. There's a guy in the dissection who had a fantastic temple bone. That was probably one of the best bones rated. So you see, I'm basically saucerizing the edges. Only one thing we should remember. So better cutting ಇದೆ ಏನ್ರಿ ಆಗ್ತಾ ಇಲ್ಲ ಕಟ್ಟಿಂಗ್ ಅಷ್ಟೇ ರೌಂಡ್ ಕೊಡಿ ಇದಾಗುತ್ತಾ maybe this will. So when you're drilling, as I said, I did a revision case recently. When you're drilling posteriorly, you have to raise the flap also. Irrigation. So we'll encounter the mastoid emissary vein. Probably this is a mastoid emissary vein here. If I'm not wrong, I'm seeing a pit here. These mastoid emissary veins, when you encounter, they will quite irritate you and they'll bleed. So don't use a monopolar cautery in such things because it will start bleeding more. So it's simple, very simple to stop the bleeding. Just put a bone wax and apply pressure. Invariably, every time it stops. However, the bleeding, it will stop.
So bone wax is what you're supposed to use. Okay, sir. Yeah. Wash, please. Very hard bone. So what I do is I thin it out. See, on the digastric ridge, you are safe. You don't have to go anterior. It is the condensation of the digastric. See here, as you drill here, it's the condensation of the digastric anteriorly, which leads you to the facial nerve. Believe me, I think one of the most reliable landmark in case you are in confusion, in any case while doing a surgery where you are doing an extreme work, then definitely the digastric tendon is the structure to go to. So remember the digastric is definitely very consistent landmark to identify your vertical segment of the facial nerve and the stylomastoid portion of the facial nerve. So I'm just authorizing this. You saw this, so much of mastoid tip is still there. Okay, can you hold the? I mean, the bone is very hard. Huh? Also, we need to drill the sinodural angle. The sigmoid, right? So you see, you drill the bone behind the sigmoid. There are approaches where we go retrosigmoid. I have done couple of jugular foramen tumors where we did something called as a POTS approach, petro-occipito transsigmoid approach, where the tumor was so big in the CP angle, going into the CP angle, that we needed a wide exposure. Just a retrosigmoid was not enough. I had to do the translap, and then we can even clip this sigmoid sinus and divide it. Okay, but then the whole thing opens up posteriorly. Of course, the neurosurgeon is also involved in those cases. Yes, sir. Yes, sir. Sir, I couldn't hear. Yes, sir. Yes, sir. We can actually lift in a bone. Lift in the sense when you remove the bone, yeah, we can definitely do it. No. Yeah, compress from outside is the standard when we do in the jugular. I'll just show you infratemporal fossa approach. Yeah. So, no. Clipping means that, not that, sir. Clipping means where we are going to divide the sigmoid sinus itself. Normally in a infratemporal fossa, here it is difficult to show because it's very friable. We just resect the lateral wall of the sigmoid sinus and the bulb. But in a POTS approach, see, because posterior to the sigmoid sinus is nothing but the dura. So when you are cutting the dura here, along with that you will be able to lift the sigmoid sinus. You don't have to lift it from this thing. So once I drill everything here, you'll see that you will only find the mastoid emissary vein and the dura. Even in a minimally invasive retrosigmoid approach, MIRA, for the semifacial spasm and other things, we just make a craniotomy here and go posteriorly. When we drill, we go drill, we go to the dura. Okay. Irrigation on. Yeah. You take a suture side and then you can clip the sigmoid. Yes, sir. Yes, we can cut the dura and we can clip. Yeah. Irrigate. I just want to show them beyond sigmoid is a dura. Okay. This bone is extremely hard. So just to orient, so you don't have to really worry, even if you go something. Only thing is you should not cause bleeding into the intracranial cavity by puncturing the sigmoid and the bulb.
or even sometimes the mastoid emissary vein can bleed into the intracranial cavity. So this is just I'm showing you to drill. I will not be drilling everywhere here. Just to show you that once we drill here, we'll go on to the dura. See, this is the dura here. Okay. Yeah, give me the curate. You have a curate. We are not going to see it like bluish here. Not like. See, once I see here, this is the dura here. Okay, still. Yeah, postcranial fossa dura, which is here. So indirectly it will lead to. I can drill some more. So I just wanted to delineate the sigmoid sinus. Normally, what we do is we delineate and we actually remove the bone or the sigmoid sinus. We just keep a little bit of a bone, and usually we go on like the whole approach in doing a translab is because we have to retract these tissues. Only when you retract the dura, you will see that pulsating dura, posterior fossa dura. We are never worried. We retract that and we go further deep. So see now here, unfortunately, it will not be the same kind of this thing. Yeah, no, this is just yes, sir. In case you do a POTS approach, you can cut the sigmoid. Now, I'm just drilling here to show the. Yeah, I'm just trying to expose the sigmoid. Of course, we can't do like this because it will bleed here if you bruise the sigmoid. But in this case, particular case, I don't have much options because it's very friable here. So I will show you what is the basically approach which we do. You take a diamond burr. Give me a diamond burr here. Coarse diamond, yeah, coarse diamond. Coarse diamond. See, this is the what I'm saying. Every as we go, when you're doing a labyrinth, when you're doing a translab approach or labyrinthectomy, and to the internal acoustic meatus, the whole idea is basically you remove the bone from the dura till the jugular bulb. Okay, what is your superior limit of dissection is your dura or the put it ampulla of your superior semicircular canal, and inferiorly it is the jugular bulb, otherwise the cochlear aqueduct, because cochlear aqueduct is just over the jugular bulb. Okay, very adjacent to the jugular bulb. We always we always transect the cochlear aqueduct. So you see this. This is the amount of this is the facial nerve is already identified. So what I'm saying is always before you do a translab approach, identify the facial nerve at this stage. To identify the facial nerve at this stage, what helps you is the identification of the digastric ridge. See, the facial nerve is here. You see this? Irrigate, please. See, so much of cancellous bone is here. This is the bone under the retrofacial. So we have approaches where we can go inferior to labyrinth and then go to the petrous apex. Okay, we can go to the petrous apex. Yeah, only is thing is the bulb should not be very high. I had a case where I tried to enter this thing, then later I did infracochlear approach because the recurrent petrous apicitis, the cholesterol granuloma, cholesterol cyst in the petrous apex. So this is how you go. In fact, this bone is into the see all this bone. You have to be careful here. Don't puncture the bulb. Okay. See how much of bone. Wish it was bluish something. It would have been much better. Okay. Oh. Yeah, course cutting is doing a better job than cutting, sir. Yeah, please. No, I am actually just trying to delineate the jugular bulb, sir. Okay, trying to delineate the jugular bulb. Yeah, the retrofacial. So you have to drill even when you're doing a translab. Now I'm going to demonstrate translab, but before that, see now I identify the digastric ridge. So that has helped me to identify this is the vertical portion of the facial now. You agree with me? So as you go here, you will get that beep sound. See here the vertical patient. Once you start identifying the vertical portion of the fascial nerve, that is when you should start drilling the posterior semicircular canal, because you know that all the semicircular canals will indicate towards one segment of the fascial nerve, like the ampulla of the posterior semicircular canal, which has been drilled by sir yesterday here, which is here, which will point towards the vertical segment of the facial canal, whereas the ampulla of the lateral semicircular canal will point towards the second genu, whereas the ampulla of the superior semicircular canal will point towards the labyrinthine segment. One more point I wanted to add: in a classical translab approach, we don't do any canal wall down. Okay. In fact, we don't even touch the extraordinary canal skin, and we don't even touch the tympanic membrane also. So only when we want an anterior extensions, because the tumor is too big. It has happened. In fact, some of the times, mostly I keep doing more jugular paragangliomas than translab approaches, because you know they go to the neurosurgeon. But couple of times, not couple of times, many of neurosurgeons call me. Reason is because the tumor is so big that they've already done one retrosigmoid approach and they could not completely remove the tumor. So they will do a second sitting where they want me to drill all this OT capsule and give it to them, so that they have the whole entire area to dissect the tumor. Some of the tumors, even then, it would be difficult to remove the complete tumor. So especially tumors which is more than 4, 5, 6 centimeter tumors which come, acoustic tumors, not easy. They'll be pressing on the brainstem, displacement and all that. So you need a good anterior exposure. So you see, I have still not punctured the bulb. You can see how much of bone is drilled here. Okay. So the medial wall of the mastoid tip, isn't it? Yeah. Medial wall of the mastoid tip. Yeah. So one thing is there. See, you can see here. Give me elevator. Give me elevator. So I have to. You have to excuse me for that. This color, this thing, because see here. One thing is convinced. This is the sigmoid sinus here. Okay. Yeah. Okay. Now as soon as I press, it gives way here. That's okay. Give me the curate. So in fact, I did one glomus jugular intact facial bridge technique. We don't have to always reroute, but it should be one of those friendly cases where you have a glomus nicely limited here in the middle ear and just into the bulb. You can do if you have enough space. If you're well pneumatized, you can do it. Okay. See now, if you see here, this jugular, the sigmoid sinus is curving here. If you see, sigmoid sinus is formed by the transverse sinus. Okay. The transverse sinus joins the superior petrosal sinus here. That superior petrosal sinus you'll get to know here, and then forms the sigmoid sinus, which continues as the jugular bulb and which continues as the internal jugular vein. Okay, give me that. So the inferior petrosal sinus, which we encounter torrential bleeding while doing the resection of this thing, that is actually you have to block with Surgicel. That opens into the jugular bulb. Okay, that opens into the jugular bulb. You see how much of space is there. So of course, when you're doing an infratemporal fossa approach, we do the neck control also. So we do the neck control, and very soon you'll see that I would amputate the tip of the mastoid. See, if you see here, sir. The bone which is separating the neck tissue and the medial bone of mastoid. That is the bone, isn't it? Which you are. Yes, sir. Yes, sir. Yes, sir. So actually, as I go drilling here, sir, I go into the occipital condyle. Yeah. Occipital condyle here. Okay. So this is, see, I can just, because we can see here, this is the sigmoid sinus which is curving here. Yeah. Okay, this is a bulb. Why we need to reroute the facial now? That is the question, because there are some postgraduates also here. Because 50% of the times, most of the bulb, 50% of the bulb is anterior to the facial canal. So if you want to have a better control over the bulb and the carotid, it is only possible when you reroute the facial now. Yeah. If facial was not there, I don't think jugular tumor surgery, if you can handle the bleeding, was a big issue at all. So facial now rerouting is a very important step, actually. Very important step, and you should also give results. I can show you the patient's results as good as you will not even identify that they have been rerouted, except that mild in the face when they smile, you'll see some deviation. So they almost get a grade 2 with the anterior rerouting. Okay. Yeah. Yeah, this is the bulb area. See, I can see the bulb there. I can just. Any question? I think we can. If it is too far, then we can have to go first. There are comprehensive criteria. Okay. Yeah. So this is the bulb area. Yeah. This is a bulb area. So main point that I want to tell you here, is that first drill this area after you identify the facial nerve. Okay. So that's why in all these cases definitely we'll be using a facial nerve monitor. You should be using the facial nerve monitor, and please identify the facial nerve. Then see, once you identify the facial nerve, your dissection becomes easy. You know where to drill. You know where to go behind the facial nerve. The focus is there. The focus little bit fine. Okay. This is. Okay. Yeah. Now, sir. Yeah. So, yeah, something. It's not. So this is. Yeah, tip is still there, sir. I'm not amputated it. I will amputate it. I'm just trying to drill for the bulb here. See, you can see amount of bone which is removed here. If you don't puncture, there'll be no bleeding until this cancellous bone will come so very easily. So you have to be careful. You should not put too much pressure, because this cancellous bone, you put too much pressure, suddenly there'll be give way and it'll go into the bulb. So yeah. So unless you're trained, you will not be probably able to handle that bleeding from the bulb. No, I can handle. I could pack with surgical and this thing. We also do certain techniques called as bulb displacement techniques. So especially you have a eye riding bulb and you want to do a myringoplasty, you don't have to be always scared. You can always use a bone wax and surgical and push the bulb down. Okay. So whatever bleeding, it will stop also. So we do bulb displacement techniques also. Now basically, I just want to drill to show you the bulb. So just tracing the sigmoid centers below. Yes, sir. Yes. Yeah. To become such a bulb. So just go on tracing. Yeah, no, actually, space is little less for me here. I can tell you, this is the, okay. No, it's okay. It's okay. You see here, now, but you can appreciate that sigmoid sinus is coming here. Yeah. The bulb should come here. So, we'll come back to that later. Irrigate, please irrigate more here. We can even amputate, and we can see in a dry bone, certain things become difficult. The bone is dried up. Not same like how I think. So, just want to, you should appreciate the cancellous bone. If I can see here, I'm seeing a small opening of the, yeah, you can see that in the microscope. Small opening of the, in the bulb. Yeah, give me the pick, please. Give me a pick. So I'll just identify and leave it here. There's no point in. See here, see here. You're seeing here. You're seeing this hole here. That means it's a bone lateral to the bulb. Oh, yeah, it's a bone lateral to the bulb. That's the area of the bulb. So give me a curate, pa. Give me curate. If at all there is a small puncture, you just have to put a gel foam and a surgical, it will stop. So these areas will bleed a lot, isn't it? Unless you puncture this thing, sir. Yeah. Unless you puncture. Initial cracking and then removing curate. No, curate I don't use. I'm only using it here, sir. I just only I make it very thin and then remove the bulb. So the bulb part I come only once I've rerouted this thing. So I just delineate here, and when I reroute, yeah. So yeah, reroute the nerve. So right now I just wanted to show you that how much we could dissect in inferiorly. Now because the approach that we are doing is a translab, the other thing I want to tell you, see, how much of the bone is removed here. Okay, so your internal acoustic meatus will run parallel to the extraordinary canal. So I think all of you know that. So now you see that once I drilled this, you can see that ivory bone, the whole labyrinthine block. So this is a labyrinthine block is exposed. Sir has done a labyrinthectomy and is gone till the vestibule. Okay, the labyrinthine block is exposed. Now I have to drill this labyrinthine block, taking care. As I said, in a normal classical, I would have the canal like this. I would have the canal like this. Here, these things have been done. Posterior tympanotomy has been done. So now I will just try to delineate the internal acoustic meatus. The crucial thing in delineating the internal acoustic meatus is, see, here, give me elevator. No, Uday, sir? Just for exposure of incarnation meatus and listener. Yes. The procedure what you have done is infra the nuclear part. Yes, sir. That is not necessary, isn't it? No, just to expose is not necessary, sir. But if you want to do a translab, you will have to drill. Yeah. Yeah, because I am showing the approach. So now see, only when then I can go on drilling here. And now I told you why it is important to identify facial now. See, I am going to stay away from the facial now. So when you're drilling this again here, as I said, sir could not, yesterday again, endolymphatic sac could not be identified because of the nature of the bone. So what we do is, give me elevator, straight elevator, freest elevator. So if you see, this is the Donaldson's line. I imagine Donaldson's line because this was lateral here, and which is the biggest ampulla, and then the posterior here. So the endolymphatic sac would have come something here like this, okay? And also, see, at every stage we remove the bone. What we do is, this is very hard. It's going to crack, so you excuse me for this. So we retract the dura like this. See, everything is, we retract the dura, and then we get a millimeter of bone that we get the bone to drill, go on drilling. So we retract the dura here, and also this is the posterior fossa dura. Recently, I did a extensive osteomyelitic case where the dura was already exposed. You don't have to worry. I did a transaortic and then CSF recalls I plugged. So dura you can retract. So in case you have also what we do, one more method we employ. This is the, say, that superior dura, like we always dissect and it's already dried up. So that is the problem here. If I do, it will break. So this also we push it and retract. Other thing is we use a bipolar. See, we use a bipolar, a good non-stick bipolar or a good bipolar with irrigation. We buzz this and buzz the dura here. As soon as you buzz, it shrinks and it retracts. And that gives you a very good amount of space to drill. Okay. So I'll show you the retraction here. So the drilling should be like this. Superior trough like this, inferior trough like this, and join that with a horseshoe drilling here. So, and one more thing which is told is that you should do the strokes. So it is, in fact, translab approach is a very safe approach. It's a very safe approach, and it is not at all, because there's nothing. Maximum you can do is you can open the, I mean, obviously you're not going to punch a sigmoid and bulb. Maximum you can open is that. One thing is you should be careful about the bulb. Not always you will get a bulb like this. You will get sometimes bulb here. So you have to be careful. Don't puncture the bulb. Second thing is, maximum you can, even if you puncture the dura or cut open the dura when drilling, CSF will come out. Anyway, that was a plan. You would have opened the dura to go into the CP angle. So now you see this. I am going to drill the internal acoustic meatus. I'm just going to saucerize this to improve my. This is coming in the way. So okay. So now basically this is the vestibule. Okay. Now what I'm doing? Yeah, you are seeing the elliptical and yeah. Yeah, elliptical and spherical recesses anterior. So now I'm just I'm completing the labyrinthine block dissection. Okay, you'll see that I'm going to complete the labyrinthine block dissection. See here, with so much of space. Usually we get, when you drill like this, around the bulb we get the cochlear aqueduct. Sometimes the bulb is very high. The bulb will be coming here also. Cochlear aqueduct, which we cut open to release the CSF, so that it also reduces the pressure and helps in retraction of the dura. One important step when you're doing this procedure is also to cut the endolymphatic duct. So endolymphatic duct, which continues from the sac to form the vestibular duct, which goes under the posterior semicircular canal. So unfortunately, all that we can't apply. Yeah, it goes under the. So I am basically drilling a trough here. This is the bulb here. This is the bulb actually here. It is all the bone here. This is the bulb. I'll show you. This is the bulb. See how wide the bulb will. When you reroute, I'll tell you. So now let me complete the labyrinthectomy to expose the internal acoustic meatus. So you can, as I said, you can go fast. I cannot retract the dura here because if I try to retract, it will break open. So this is how you go. Give me a small diamond burr, coarse diamond burr. So horseshoe drilling. So the stroke should be posterior because, as I said, maximum you're going to hit the dura, right? Yeah, sometimes what happens is when you're doing a massive acoustic, you'll realize that the tumor is already protruded into the dura. So the dura becomes friable. Can you hold like this, please? All these areas will friable already. Yeah, tumor sometimes the tumor will be protruding. Only thing is that you make sure that all the bone is removed, and then only you kind of try to open the dura. Don't open the dura before you remove the bone. Okay, give me that forceps. Yeah, we have to, of course, protect the facial now. Give me a small, smaller. See here, what I'm trying to do. I'll show you the U-shaped trough, which I want to do around the to identify the internal acoustic meatus. What should not be done is directly entering the internal acoustic meatus. If you go directly, you will go into internal acoustic meatus, but you will take off all the nerves. The whole purpose is defeated. See, I'm keeping the dura. Usually, sometimes with the suction, I retract the dura, and I am actually making a trough superiorly, trough inferiorly. Okay, this is actually the bulb here. The bulb is here. Okay, you see this bluish structure here? Can you see here? My burr is on, that is a bulb actually. This is the bulb. This is a bulb. So you see how close it is. If you don't expose, you will puncture the bulb. So I am doing that horseshoe joining here. The bulb here. So this will be useful in some cases. We have had cases, young people with good hearing status, but when you see their CT scan, you will see that cholestoma is going all the way till internal acoustic meatus. So all of them want good hearing, but it is not possible. But unfortunately, they had good hearing doing surgery. So those are the situations. You don't have to do only CP angle. Even for an extensive cholestoma, these approaches are very useful. And second thing you will see from yesterday, what we are doing, all these approaches are a continuation of one approach or the other. So this is a continuation. So now what I'm doing translab is basically an approach through the otic capsule. We have some approaches which go inferior to the otic capsule, like an infratemporal fossa A approach. We have approaches which will go middle fossa, which is superior to the otic capsule. So this is which is going through the otic capsule. Okay. So in fact, even in live surgery, this drilling is a very challenging superiorly, because the last bit of bone is very hard, and you have to remove every bit of bone till you get the dura. See how I am just going. This is a wide approach we should do. Only then, I mean, honestly, in a massive acoustic tumor, nothing like unfortunately, neurosurgeons are fixated, some of them, with the retrosigmoid approach. But massive acoustic tumor, nothing like a translab, especially if the hearing is also gone, nothing like a translab approach. Will give you a direct access into the CP angle with very minimal retraction. And the patients, once they're done with the surgery, within 3-4 days, they start walking better. Okay, the balance is better, they walk better, and they can be discharged better. Okay. Yeah, hearing, but yes, sir, yes, sir. So one more thing, what they tell is, even if they preserve the hearing with so much manipulation, invariably the hearing goes. So I think safe. Ultimately, what patients sometimes ask is, have you removed the tumor completely? That is also one thing. See how I'm doing a trough? I'm hardly bothered to go behind and drill here, because maximum I'll open into the dura. That's all. See this? See how much of white space we get. Okay? Sir? Singular nerve is not seen. Yeah. Posterior ampullary nerve, sir. Okay. Yeah, that goes into the towards the round window area, but all that we can see once we open the interlacoustic meatus. In the internal acoustic meatus, along with those four nerves, we also see the nervus intermedius, which is attached to the facial nerve. Okay. Yeah. Yes, sir. If you encounter a subpathway artery bleeding, yeah, how will you encounter it? Just drill it, sir. Drill. We are, yeah. Once we identify, I mean, in a translab, so with no issue, we drill, go on drilling everything. So whatever comes in way, except the. So before you open the bone or the interacoustic meatus, the subaqueous artery is actually the persistent petromastoid canal. It runs in that comes in the center of your what do you call that? Yeah, the solid angle. Irrigate, please. Because it applies ಅಲ್ಲಿ ಇಂಟರ್ಕಾಸ್ಟಿಕ್ ಮೇಟರ್ಸ್ ನೌಸ್ ಇದೆಯಾ ಆ ಕಡೆಯಿಂದ ಆ ಕಡೆ there's a problem. The dura is going to give way. See, I'm seeing some nerve here going here. Could be the fascia. But see, the idea is to demonstrate. I see. Unfortunately, I can't do retract this dura, and that is hold like this, and the angle is also a little difficult here. So that is there. So important to. So this you should practice. Translab is one. It's like a mother of approach because rest of the approaches you build on translab approach. See here, you can see that blackish thing that you're seeing. That is a dura. Posterior fossa dura. That's exactly. Now, hope it doesn't give here. But thing is that don't open this dura till you remove all the bone. See, once you come onto the interacoustic meatus, please thin it gently. Okay, gently. Okay, I am trying to be fast here, of course, but usually we go fast also because sometimes when the tumor is there surrounding the interacoustic meatus, you will see that tumor gives you that hard feeling down. Yeah, they'll be very good. Always use the biggest burr possible, whichever area. Okay, so yeah, yes. Yesterday I said something which was wrong. I had to do a small correction. When I told that to identify the landmark, say mastoid antrum, it is the McEwen's triangle. Yeah, McEwen's triangle. Yes, it is correct. But of course, I always follow the Tegman plate. But what I told my boss is that the spine of Henle. So because we always, if you see in the book, it is told even when we were like spine of Henle and that mastoid antrum comes 1.5 centimeter deeper the McEwen's triangle posterior superior to spine of Henle. Now, in many cases, you will not see spine of Henle. And nowadays, whenever I start surgery, because I said I do intact canal wall technique, intact skin tube technique, and when I raise the extraordinary canal skin, I find the spine of Henle, which is sometimes it is in weird positions. You know that sometimes it is very small, sometimes very sharp. It comes in the way. I always do canal plasty, and I keep raising the canal skin. So that is also one thing. So I just drill off the spine of Henle. So the elevator and I did some most often. Yeah, I do sharp dissection and I do with 15 blade and sometimes with this thing. So why I'm saying is that never say that spine of Henle is your land. Don't take spine of Henle and say I'll go posterior superior to that and I'll open the mastoid antrum. I think it could be in risk. I can show you many times when I'm operating. There's no spine of Henle only. So how would you take it as a landmark? So yeah, so that is the message that you have to draw. So McEwen's triangle is still good. I mean, so now I'm going with a cutting burr because I wanted a smaller burr because smaller diamond idea. See, the orientation of the interacoustic meatus can be different. Don't expect that it will come straight into you. It can be little twisted like this. Okay. So anyhow, we have preserved the nerves, and I just want to use a diamond here. I don't want. Idu kodiyappa. Idu kod. Yes, sir. Parallel to the extraordinary canal. Yeah. Parallel to the. And yesterday, sir was telling that any knowledge which we acquire is good. I mean, somehow it is used. That is so very, very true. So very, very true. In fact, so many a times, even when I remember once when I was in Polachi, there was a CSF league case which was being operated by during NCCon by Professor Kirtane. So he asked me, "Can you take facial art?" Many a times I've learned by saying yes, though I have never taken it. You just have to read the book and just see the video and just take it. So why I'm saying is because you have to know to take graph materials, various types in ENT. Like in this kind of approaches, the abdominal fat for me is very, very important. Okay, abdominal fat is an important graph, and even these approaches which you learn, I saw some people like no, maybe it's too much for them and all that. No, definitely whatever you learn, it's going to be useful as you do more and more. You'll realize that no, at least if not to read the scans, see how nicely the intracaustic meatus has been opened without going through the intracaustic meatus. Okay. Dura is approaching. Yeah. Dura is posterior fossa dura is being approached here. So this is the see the bulb is so high. See, I mean, sorry, what I'm saying is bulb is see the difference. Had I not drilled this, how will I identify that so much space is there? The whole idea is to give a wider approach to remove the tumor. There's no point in doing a small approach unless see if you have a simple cochlear aqueduct, what you see. So, yeah. This could be the cochlear aqueduct, sir, somewhere here. Yeah. ಸ್ವಲ್ಪ ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಮ್ಮ. Yeah. So cochlear aqueduct. So you see here how I'm just see I'm using my suction as a guard. The suction yesterday I saw some of the people using one hand. Okay. So one hand to drill. So better please use. Yes, sir. 1 minute. 1 minute. Yeah. 1 minute. So I'm using this suction as a guard. The suction goes around all around the burr. Okay. Like a wanderer. See, you have to keep it very stable. Drill a trough. When you drill a trough, you can keep it stable. Okay. Is it seen, sir? It's seen the. No. So cochlear aqueduct is actually your inferior limit of your drilling, or otherwise you can call it the bulb also because it is very close to the bulb invariably. Okay. And cochlear aqueduct, we always open the cochlear aqueduct, and that is when the CSF comes out, and then the dural retraction becomes more. Okay. So it opens intracranially, sir. Yes, sir. So you see the intracaustic meatus. So in fact, even in live surgery, I find this portion of the tumor removal most difficult because so hard. Sometimes you go on drilling, and you see one more point I wanted to tell you is here we could not do that because it's going to break here. So we remove all this bone here. This is you're seeing a vein here, vessel. Yeah, this vessel here. This is the superior petrosal sinus. So we always leave a triangular bone here attached because it is protecting the superior petrosal sinus. In the last, the triangular wedge-shaped bone we remove from the sinodural angle. So again, we should not cause any bleeding from the superior petrosal sinus. Okay. So this is actually superior petrosal sinus here. Okay. Yeah. So we usually remove and keep a ledge, and last using an elevator. You thin. Basically, you have to thin the bone like eggshell. Okay. That's the only option. You can see here, this is the superior vestibular nerve here. Okay, that is continuing here. See, if you see, okay, I'll just show you the curate because I'm just wondering, trying to drill more, considering in this situation, we might end up opening this thing. So this is the cochlear aqueduct. Okay, this is the cochlear aqueduct. We drill and we curve piccoli. Yeah, this thing. And second thing is that see the orientation when you see from a middle fossa approach to a translab approach is different. Here you will have these four nerves. See, normally what we are told is to preserve the ampulla of the superior and the lateral semicircular canal till the end. Here it's already drilled because that will protect your nerve, the facial nerve. Yes. So this is your superior ampullary nerve. Superior ampullary nerve, which is coming to your vestibular nerve. So you see this ledge of bone. This is, if you remove this bone, what you get, feel a bone behind is the Bill's bar. No, we are towards the fundus now. Fundus. Porous is down towards the CP angle. Yeah, porous is towards the CP angle. Irrigate Madipa. Yeah, we already, actually nicely we have seen. Shreyas will find that this suction has become sharp. End of dissection. So irrigation, please. See, this horseshoe gives you the thing to open. Okay, this horseshoe, you should do this horseshoe drilling. Safe. Translab is a very safe approach. Actually, when, if at all do a chance to do a translab, if you have time, whenever you are worried about any other risk, the only challenge is once you do the translab approach, you open this, you have to preserve the facial nerve and remove the tumor. That is a challenge. And also you have to do a blind sac closure. Yeah, blind. Sorry, in a classical translac, we don't do blind sac closure. Not necessary. But if you are doing the canal wall down drilling, all that, yes. And in a classical translab, you don't do blind sac closure, but you have to plug the eustachian tube orifice from here. Here the canal is there, so you go from the attic. The very important step that I used to see Professor Sarna even at this age is, I think now 77 if I'm not wrong, because when I was there he was 72 or 72 something like that. It's been 5 years, so it should be 77 or 78. I never saw him after. He just basically comes when the tumor dissection is there. He does the tumor dissection and he plugs the eustachian tube orifice all by himself. Never lets that anyone else do. And he always does. Look what I'm doing here. He plugs all the air cells with the bone wax and this thing, because you don't want CSF rhinorrhea. Okay, and basically we put strips of fat, abdominal fat, and we close off the cavity. Okay, so I'm using less pressure here, though I'm drilling here. Can you give me one small size smaller drill? Yeah. Diamond the last. So this is the Bill's bar. Give me that sickle knife with you. So these are visible after removal of the. Yes. They are the structures. Like yesterday, somebody asked what is crotch. Developed after you do the dissection. Okay, they don't. They're not there as such. They are actually not imaginary, but they are actually developed by drilling. Okay. See, nicely we have removed the bone. This bar is always there. It is not developed. This bar is there, but when you open the dura, you know the identification nerve only you can find out. Yeah. This bar is always there. What are the things of always? It is a bone. It is always there. It's a unethical landmark not developed. At least you can write. Yes, sir. Yeah, it is. Yeah, there is a bone. There is a bone. But as you said, probably the visible. ಸ್ವಲ್ಪ ಹಾಕಿ ಇವಾಗ ಸ್ವಲ್ಪ ಹಾಕಬೇಕು ಇರಿಗೇಷನ್. No, the detection is coming out very well. It is coming out very well. See how much of space you get. Almost about 4 centimeter or more. I'm sure you'll get, and I think one should not have any problem. This cochlear aqueduct is here. Irrigate Madi. We open and let out the CSF. Okay. So if somebody asks, that is your inferior limit of your dissection is a cochlear aqueduct. See that? Cochlear aqueduct, that you will damage the Yeah. Still, this is so basically you have a trans labyrinthine approach that has been modified by doing something called as a transapical extension. Basically, in a you see now, for example, I have exposed 180 degree of the internal acoustic meatus. Okay, so I drill this all around like this. So we have a type 1 and type 2 modification where 270 degrees we can encircle the internal acoustic meatus. Okay. So beyond that, when the tumor is going way anterior, that is when you have to do other approaches like transaortic and transcochlear to get complete control. A transcochlear approach is like the most widest approach that you can do. I did for one Peters bone cholestoma. We're rerouting the nerve posteriorly, where you the whole brainstem, the anterior, as the tumor goes anteriorly towards brainstem, that becomes a very ideal approach, bone removal. That is. To show this as a last procedure, not today. Yes, sir. We actually this is the mine we're drilling, which has taken time. Yeah. After this, it should not take much time because just continuation. Just that rerouting the facial now might take some time, and then we are actually remove the canal. We have to remove the canal. So this is the. If the dura is intact, that is the reason we are not having the nerve. Nerve normally appears like a whitish structure, which is seen, but I'm just trying to free all this. So only thing is that I don't want to suddenly go into the intracoustic meatus. Yeah. That's why I'm trying to take time and. But the porous area where you are doing. Yeah, that's the porous area. I don't mind opening the dura. I think time has come when we'll open the intracoustic meatus because there's no point in. Let's not waste time. I'll just drill a bit here. I don't want because once the nerves become free, they'll get sucked into the drill, which I don't want happen. See how much of this in real life also. This bone is removal is one which frustrates me because you keep on drilling and it gets harder and harder as you go inside, and then no. See already this glove is torn here. Yeah. Can you give me a glove? Yes, sir. It is open. I in fact wanted to open it because that makes life easy. A little bit of dural covering is there over the internal acoustic meatus. I'll just drill a bit of bone and then I'll take the curate so that ಸ್ವಲ್ಪ glow ಕೊಡಿ 7 or 7.5. 7 ಇದೆ ನೋಡಿ. Okay, we'll not waste time. ಅಲ್ಲದ್ ಬೇಡ irrigation ಮಾಡಿ. Yeah, but one thing is if you want to do these kind of approaches, you should have a love for drilling. Otherwise, it is difficult. Yeah, you have to develop that aptitude to sit for some hours and drill. Otherwise, it is difficult. And till now, what I have seen with the neurosurgery, see how the nice horseshoe, U-shaped, trough on either side. See still how much bone. In fact, now I am already doing a transapical extension. Yeah, I have already gone like at least more than 180 degrees for sure, 220 and 270. So I have opened nicely. That bone glow ಕೊಡ್ತೀರಾ? But in a case of acoustic Europe, yes, sir. Instead, you would have seen that you were there, actual cracking of the bone. You would have. Yes, I mean, yes, sir. I mean, if it is a massive tumor, yes. Yeah. Massive tumor, but generally, as you said, I have already mostly got opportunities for massive tumors only. So yes, you will get some tumor there. So we can't drilling the bone, and I sometimes use this or that bone nibbler. Yeah. I use it to just take off the bone because see, you have tumor down. There's nothing that much you'll lose by meddling there with a bone nibbler or anything. So my whole goal would be just to preserve the facial now. But again, that depends on the tumor and how much it is. So I'll open it posteriorly only. Yeah. So I'll just leave it here just to show the. Yeah, I mean this is a porous, the CP angle dura. So I'll just open it here. Only one thing I want to show here is that the superior ampullary nerve. See here, I'll just drill this. You see the facial now. So one more thing is, yeah, when you're drilling for the vestibule, you should be careful about the facial nerve. You drill inadvertently here, you will going to cut the second genu of the facial nerve. So here, sir, here when you're drilling here, because here this bone is also drilled here. This is a transverse crest which I'm drilling now. That bone, you can see that bone between the two nerve bundles, superior and inferior vestibular nerve. That's a transverse crest. Here I will just drill a bit here to follow the superior ampullary nerve. I'll tell you why. ಸಣ್ಣದು ಕೊಡಿ ನಾವು ಸ್ವಲ್ಪ. Yes, sir. Yes, sir. Give me drill small, just one small little bone, sir. I'll remove that. Delegates, you have any problem now to identify the superior vestibular nerve? Because what we do is we have to identify superior ampullary nerve so that we don't injure the facial nerve. Only when you identify superior ampullary nerve, we can be able to lift it up. Yes, sir. No, superior vestibular nerve is down. That twig that comes here. Yeah, towards the ampulla of the superior semicircular canal. This one, because we lift it from there. That means we are going to lift the superior vestibular nerve. Otherwise, we might lift up the facial nerve. Yes, sir. Yes. Give me curate. Give me curate. Yes, sir. I will open it, sir. Now, give me curate. Give me curate. Sun curate ida. Yeah, well, it's a smaller curate here. See, this is just a bone here. You'll see here. Facial nerve illay ide. So the labyrinthine, whatever you say, no segment, superior ampullary nerve is here. Okay, this is a first genu, right? This is a first genu. Here we can actually this part I even seen prof nibble it with the curate. So this is the superior ampullary nerve here. So I'll remove that once. Sir, this is the superior ampullary nerve. You're seeing here, sir? Superior ampullary nerve is getting from the right dot. Yeah. And then one more thing coming from utricle. They both form the superior. Yeah, this is the cochlear aqueduct. We'll just open it just to show you. Still this bone around, that's okay. This is a superior ampullary now. I want to keep it right now. You see that's now nicely give me cord pick, please. Because center the give me sickle knife. So this is the see here, this now here. Yeah, this is a superior ampullary nerve here. Continues as the superior vestibular nerve. So normally what we do is we lift it up, cut it here and lift up the superior vestibular nerve. Facial nerve is behind that. I'll show you. This is now what we'll do is we'll open the dura of the internal acoustic meatus. You have iris scissor there. See, this is a dura of the internal acoustic meatus. Give me iris scissor, boss. Give me the small suction tip, Kodi. Iris scissor, suction tip, small, Kodi. Yeah, so what I'm saying is, see, this is the dura. You can see here the dura. Yeah. The iris scissor. Okay, this is exactly what we do in real life also. Just going to cut the dura and separate it. Nothing to worry whilst cutting the dura posteriorly. Any of this dura has to be cut. Okay, so this is the dura. So one should do a wide exposure of the internal acoustic meatus like this. Huh? So I'm just cutting the dura here. Now you can see. You will see 4 nerves, but I don't know. Now you are seeing 2 nerves. Yeah. Yeah. Give me that bone nibbler kodo anta little. So this is into the CP angle. You will see cerebellum here. Yeah. And the brain. Yeah. ಇದು ದಪ್ಪ ಇದೆಯಾ? ಓ ಇದು ಆಗಲ್ಲ ಬಾಸ್. ಕ್ಯೂರೇಟ್ ಕೊಡಿ ಒಂದು. ಕ್ಯೂರೇಟ್ ಕೊಡಿ. I just wanted to fracture this bone. ಮಾಡಕ್ ಹೋದ್ರೆ
So now just give me same sickle knife for that iris scissor. Iris scissor ಕೊಟ್ಬಿಡಿ. Now the structures to be shown, I'll just cut off the superior vestibular now because then I can identify the facial now. Okay.
Before cutting the vestibular nerve, no?
Yes, sir.
Just develop the plane between the superior vestibular nerve or inferior vestibular
Yes,
nerve.
sir. Yes, sir.
And then deeper to them, you can see the cochlear nerve, the
Yes,
facial nerve, and the same.
See now ಅದೇ ಇಲ್ಲಿ ಏನಾಗಿದೆ ಅಂದ್ರೆ see according to me this is the yeah but difficult, that's what difficult. So but still I think we are able to separate here. So suction block karo, suction block ಮಾಡಿ. Yes. Yeah, give me without suction I'll do. So see this is the superior vestibular nerve. Okay, how you know it's superior vestibular nerve? Because it continues with the ampullary nerve. Give me ಇದು ಕೊಡು, sickle knife ಕೊಡು. And behind that is your facial nerve.
Yeah.
So this is the superior vestibular nerve. Okay, and behind that is 100% whatever now you get is this is superior ampullar. So that's why we remove this, and this usually we put a probe here, we feel a bone between the superior vestibular nerve and the facial nerve, and that is your Bill's bar. Okay, and see now I'm going to separate this facial nerve here and keep it here. Okay, this is definitely facial nerve, it's thicker here. And then this is the transverse crest. You can see, appreciate this, between the superior and the inferior vestibular nerve, and this is your inferior vestibular nerve. And in live you'll find a nerve which is thicker and whitish compared to the other three nerves. So that is your cochlear nerve, which is anterior. Okay,
And it is inferior.
Anterior, and so see it is here.
Out of all these four nerves, which is thicker?
Cochlear, sir. Cochlear is a very thick bundle. In fact, it is very obvious. You might get confused while identifying facial and other things, but not with the cochlear. Cochlear is a very thick. So I was reading a book. So 3,000 fibers, 3,500, or I think it is not 3,000, 3 million. Fibers, ganglion cells, which form the fibers, and then that is when you get the cochlear now. So this is actually inferior vestibular nerve. Okay, in intractable meniere sometimes I do vestibular neurectomy, that is with the inferior vestibular nerve. Okay, no sir, I mean I have not done in vestibular neurectomy for anything, but it is done retrosigmoid approach. Okay, so this is the cochlear nerve, sir. This is the cochlear nerve. Yeah, so you can see the four nerves nicely identified and preserved. Sir, singular nerve, honestly, I don't know. Singular nerve is somewhere here in the round window niche. Here. Yeah. Yeah, it goes there. We have to trace it here like that. It probably will have a feeder, but I don't know whether we'll be able to identify. Okay, but at least the interacoustic meatus, one is sure that all the nerves.
It goes under the floor of the round window.
Give me curate pause.
Before it joins the
Yeah.
Thank you.
ಇಟ್ಕೊಳ್ಳಿ. So this is finishes the translab approach. Okay, so now
nicely done, Uday.
Thank you, sir.
Kind of difficult code.
Yeah, I wanted to make sure that at least the nerves are shown, otherwise there is no fun in this thing. So give me the drill. So now one more thing.
Magnify and show the transverse crest and the base.
Yes, sir. Yes.
Only these two things.
Magnified, sir. Now.
Yeah, it's magnified. And take the probe and.
Yeah, nicely magnified, I think. Yeah. So again, I'll just repeat. This is your superior ampullary nerve. Okay, and then continues as the vestibular. Vestibular nerve. So anyhow that we had to do, this is wanting to come out. So anyways, we'll not do with the facial. So this is a facial nerve here, very friable, and this is your inferior vestibular nerve. You can see the dura, and this is your cochlear nerve. So this is a transverse crest between your superior vestibular and your inferior vestibular. What separates is the transverse crest. So this, and if people, this is actually the floor of the vestibule is nothing but your roof of your interacoustic meatus. So what you should understand is that when you're drilling in this area, you're very close to the facial nerve also. So there's no point in you saying that I'll preserve the facial nerve, but I took out the facial nerve here. That is very important. So that is what I'm trying to tell. Second thing is this is a transverse crest, and the Wills bar is behind, and it has been. One thing is transverse crest, another is vertical. Vertical. Okay. But in this orientation, you will not appreciate with transverse and vertical. But through the take a bone and put an otoscope through the forest, see, then you get the orientation. The horizontal crest is really horizontal and vertical crest is really vertical. The anatomical position. Now here it is tilted. So that's why you will appear to see the continuation. Which one is? Here, we'll do it later when we're doing the canal wall Tagitivala. How we can do then. Yeah. You said one statement today. Yes, sir. That the floor of the vestibule is roof of the intronic event. Yes, sir. Is it the floor of the vestibule or the medial wall of the vestibule is the medial wall. I mean, that's what I meant. Medial wall from here. Yeah. Medial wall of the vestibule is basically the roof of your interacoustic meatus. Yeah. Because PGs are here. So this is the fundus, and down is the porous. Yeah. So down is the porous. So one more important exercise. So this translab approach, believe me, I mean, don't think it is only for acoustic tumor. With a little bit of, now I have an experience about 80 cases of skull base and some cases of very bad cholesteatomas. In fact, I enjoy otology more. So what I'm saying is it is really helpful in many situations. I have cases with anomalous mastoid vein and all that. So where even the blind sac closure is a very important rescue thing which you should learn in difficult situations, which helps the otologist to come out of those situations. Okay. So now I wanted to do one more thing. See, before that, this exercise you have done the intact canal wall and the transplant. Okay? Yes, sir. Yes. Put the tumor. Yes, sir. Now you are saying you are not going to do any blind sac closure. So yes. You close this blind. This whole thing is closed by abdominal fat, sir. We take abdominal fat. Yeah, we'll. Yeah, we are putting a portion of the fat into the intracranial cavity. Strips. Nothing will happen, sir. I mean, nothing will happen. Strips of intracranial fat, will cut it like a linear strip. We'll put some. Of course, you should know how much to push inside. So we achieve hemostasis. So we thoroughly irrigate the area and look with like I was Professor Sana so particular even about the smallest RBC. He uses something called as a Vesalius bipolar. He just does the whole tumor dissection using a bipolar and a iris scissor, something like that, and a forceps. No other fancy, not even a CUSA. So sometimes we here use CUSA. So what I am saying is that once we achieve hemostasis, we flush couple of times. We place some Surgicel on the brain surface, some thin strips of Surgicel on brain surface. Then we put linear strips of fat and fill this cavity. The most important thing is closing the eustachian tube orifice, closing the air cells, and most important thing, one thing they will never allow you to do. I was a hands-on fellow. I used to scrub and drill also. They will never allow you to do the soft tissue work, because every that soft tissue work, they don't want any contraction of the soft tissue work, and they want that to be sutured tight. Okay. Proper. There will not be even a millimeter of space in the soft tissue work. The flaps, all the flaps will be approximated nicely. But so whatever you said, it will not be watertight closure. So there will be some amount of CSF. Sir, no gap is that will be there, sir. But thing is that the flaps are approximated with. No, nothing, sir. No drain, nothing. Just close it and close the periosteum. It will be a very tight seal. Nothing. In case there is sometimes there is a small rent which happens. Basically, they want a complete closure. Okay, small rent. They will rotate the temporal fascia and they'll rotate down and they'll stitch. Probably like how we were doing other day. Basically, we want to stitch. So one important exercise I want to show you, which is probably very useful, is the lateral temporal bone resection.
See, 50% of the job is already been done here because of posterior tympanotomy. We have identified the cauda. So honestly, very difficult to get a case which suits a lateral temporal bone resection. But I have done a couple of cases even in advanced cancer centers where I did lateral temporal bone resection with superficial parotidectomy and selective neck dissection. So a case malignancy of the temporal bone which involves extraordinary canal, we do lateral temporal bone resection. So basically, of course, tympanic membrane is kept, the malleus is cut and removed. So we are just going to follow like this old this thing. You remove the whole thing like a tube shell. Okay. So here I may even fracture it to just avoid this thing. See, encircle the extraordinary canal. Okay, but see, I'll tell you, there was a time in about a year or year back, continuously every week I was doing on temporal bone malignancy for about 3-4 weeks. It came in crops, and after that I never got a single case. Why I'm saying is lateral temporal bone resection, very few cases, but subtemporal bone resection is what we call if there is a tumor which is involving the mastoid and all that. So we do a piecemeal resection and then do blind sac closure, and of course you send them for you make sure that this margin is clear, chemo radiation, and I have a follow up of the patients. They're still doing very, very well. Okay. There's one patient where the pinna had to be resected. We closed like that, but otherwise, they're still doing very, very well. And squamous carcinoma, sir. Squamous carcinoma. But generally, if it is too much of involvement of the dura and all, the prognosis, actually, there's no proper staging for temporal bone malignancies, is what is being told, in the sense only for squamous carcinoma. But there are other carcinomas. If the tumor is involving the dura and between certain point like the carotid and all that, it is better not to operate such cases. Send them for chemo RT, because as such the 5-year survival rate is very poor. No, sir, no. I've not done a case like that. And I've also one more exercise where I was called, because see, basically the whole idea is that I don't want the audience to be disappointed that why are we doing all this. And there is a reason why we are doing. Believe me, head and neck surgeons called me. There was, again, these things come in crops. Deep lobe parotid cancers, which involve the tumors, which involve the facial nerve. So they call me to do this kind of a resection, free the facial nerve, and then amputate the facial nerve. So you will see that the facial nerve is bulged here. Okay, when the tumor is infiltrating from the deep lobe cancer, it is bulged here. You will amputate the facial nerve and give them a stump. So I do that job, and then later the plastic and the reanimation part they take over. So with the fibular graft and all that. So even in those cases, the drilling of this temporal bone is important. If you want to get a tumor-free facial nerve in deep lobe parotid cancers, that is also, this dissection is very. No, you don't have to drill translab, but you drill like this. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Malignant otitis externa cases. I've been only doing subtotal petrosectomy, blind sac closure, but I drill anterior to carotid artery. I'll show you. Or I do infratemporal fossa type of A approach, because sometimes I see the disease goes in areas like targeted approach is what I call it. So sometimes the disease is all in the stylomastoid foramen here. Recently, I did a case I showed you other day to some of the delegates who were dissecting. The whole facial nerve was covered by mass of tissue. So I literally dissected out all that granulation and preserved the facial nerve. So it is all like depends. Some cases you have the abscess going, you see the bulge in the nasopharynx and abscess going anterior to the carotid artery. So there you will have to decompress that area anterior to the carotid, that is a clivus area. So all this is important. Then targeted correction. So sometimes I did for a couple. I've done I think around 25 cases of skull base osteomyelitis I've operated, and I can say leaving 2 deaths which happened due to other reasons, not definitely post-op. So one due to stroke after 6 months, and one I was told that he was not doing well in spite of medicines. So with abscess and all that after a few months. So what happened is that these patients, but I say majority of them are doing extremely well, sir. If not anything, the pain scores. But only thing is that selection of the cases. Even now, on for the first time, probably this Thursday, I'm doing a follow-up case of skull base osteoarthritis. He's been following up with me for some time. In his case, what has happened? Hearing is very good, but the disease somehow is there is an improvement in MRI, and it is getting localized to the mastoid. So his son-in-law is a surgical oncologist. So I've told him like we will just do an extended mastodectomy, because he has some mastoid tenderness, and we'll follow it up so that you can reduce the load of medicines on him. Now is on oral medicines. So there are a lot of patients, once you put medicines, there's one more patient, once you put medicines, they do really extremely well. So such patients, don't disturb them. So don't disturb, and indication should be correct. So 90 localized disease, if you do, you get good results. Yeah, so targeted this thing. And I also had, I mean, people saying some central skull base is involved and all that. Generally, I very choosy, like when I'm operating, like I want a proper selection of the case so that the results are good on the patient. See, usually we put them on with culture 1 month of injectable antibiotics. Nowadays, what we find is meropenem is the one which is most sensitive, but at least responding to meropenem more than piptas, and I prefer that ones at least should take some culture sensitivity. The other idea of doing a surgery is to take a tissue for saline. But believe me, tissue for culture in saline, but believe me, most of the times, more than 70-60% of the times, we don't get any positive culture sensitivity because already they have been put on many medicines. Okay. And also the patients we have operated have already taken 3-4 months of medicines. In fact, they'll. It is the endocrinitis. Diabetes, no. It produces endocrinitis, and that is actually causing the necrosis of the tissue. Isn't it? Yes, 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 sir. Yes, sir. Necrosis and lot of granulation. And maybe the recession itself is not the main pathological factor in malignant. What I observed is HbA1c more than 6.5, very bad cases. So HbA1c control, sugar control is of course. Are also diabetic. They are not diabetic. Yeah, some of them are having renal problems, and some of them are also having cardiac problems. So reduce pain scores. Yeah, but definitely I have at least patients who are follow-up since last 3 years. They're doing well. I mean, you cannot say that they may have some issues, but generally most of them are doing well. Probably, I think the selection of case is also equally important. So now what I think, I'm just wanted to show you lateral temporal bone resection. So just remove it like a sleeve. So I will not honestly waste time trying to dissect, remove it like a en bloc, no, because it is going to unnecessarily consume time, and we are not going to achieve anything because there's other things to do. So I just want to see how we circle, because intact tympanic membrane. Yes, sir, intact tympanic membrane. Yeah, of course, sometimes the mass is there in the extraordinary canal and tympanic membrane things will be little distorted. But with the malleus and with the annulus also. Annulus, we raise through that. So you see how I encircled here, and I just will show you for some more time, and then is the magnification high? I think, no? Better, sir. So this is a lateral temporal bone resection. This is also, I'm sure you'll get temporal bone malignancies, I think, are quite related, though rare they say, but it is common in India. Not that you will, I'm sure people will find this fleshy mass polyps. You should be very, and you get one of the thing is get a CT scan and MRI scan. Look for lymph nodes and look for parotid also. So I will just show you this way we have drilled. How you can encircle. Honestly, even in live cases, after drilling this much, sometimes because see, anyhow this will be drilled, the whole anterior canal will be drilled till the capsule. Then I use a monopolar cautery to cut that bone from the capsule. Same thing in skull base osteomatis, because if I have to drill anterior to the carotid, I need a good control. Like other day also we did the glomus. I need a good control over the anterior canal wall. That is very, very important. So I'm just going to fracture this. Give me that bone nibbler, pa. So I just showed you how we do this resection. So any tumor, so that sleeve resection, I think it is basically not really worth it. In case you have a tumor in the anterior involving the canal wall, at least do a lateral temporal bone resection. Okay, I'm going to fracture this bone. Let's not waste time. So you'll see here. So see how this tympanic bone drilling is important. So give. Yeah, now this is indirectly we did a canal wall down also. Canal wall down. Yeah, give me a big cutting barbos. But it can be done as an isolated procedure, isn't it? Without, yes, sir. Yes, sir. Isolated procedure. Without without exposure of the patient. Yeah, yeah, of course. Facial canal, yeah, will be there. Dealing the tympanic bone. Yeah, drilling this. Sir, sir. Yeah, yeah, yeah. You do an extended cortical, like how yesterday you did. Shays was doing that, demonstrating the anterior attic and all that. No, you demonstrated. Yeah, yeah, of course. Then only you can come around, sir. So once you've done this, the skin here. Sir? Yeah, yeah, posterior tympanotomy, sir, above the facial. Yeah, yeah, yeah. So give me a flag knife. I'll remove this drum. Huh? Flag knife, please. Flag knife. See, one of the I wanted to tell one more thing. See, the yesterday about endoscopic ear we were discussing. See, there are definitely some limitations of endoscopic ear surgery. See, the one thing is that retrotympanum is one area where a microscopic surgeon might find that area to be blind. But though he does the surgery and there's no problem, you can always tilt. Now, I think one reason why people sometimes they don't like microscope is because people are hesitant to tilt and move around in the chair. This is even I feel sometimes lazy. So I think we should develop that thing to tilt the head, move the chair under and tilt. So then I think we can see. But yeah, endoscopic, whenever you do combined approach, say the cholesteatomas, which involve the sinus tympani and retrofacial, I always tend to check with the endoscope. Okay, the retrotympanum. The retrotympanum, basically all that you are talking, sinus tympani, ponticulum, subiculus, the styloid. This is the basically tympanic bone. As you drill the tympanic bone, you will get the base of the styloid process. Base of the styloid process. The whole styloid complex is what continues as your retrotympanum here. So styloid complex continues as a retrotympanum. So here, see again, ossiculoplasty is working. Huh? Any doubts? Yeah. No, I can't hear actually. And, I just had an opinion. So they say that you guys 360-degree drill out of the entire lifted out around the yeah, yeah. With this process, what they the Tata people have suggested is you keep on suctioning out and keep on sending the suction material for histopathy. The moment it is negative for manifest, you can stop it. Yeah, we actually do a frozen section. I mean, this is what I've been following. This malleus, I think, should we remove it off? Now, I think time to remove it, right? Let's not. So we'll do. Give me that probe. Yeah, forceps. So we'll remove the malleus because this is one thing which radical surgeons should get used to, because we generally used to preserving ossicles nicely and doing all that we do. So this is a tensor tympani tendon. I want to tell one point here for those who, because again in cholesteatomas we do get this challenge. Where is the facial now? So one thing is, see, this is again very classical case. This is a facial now here. You agree with me? Already there's been identified and delineated facial now. This is a tensor tympani. Yeah. The facial now will always run above your canal for tensor tympani. So, because I'll tell you, I mean, you will say, why is he saying? Of course, we know that there's a canal for this canal here, tensor tympani, and you will have also the greater superficial petrosal now going here. So, this canal for tensor tympani, you will see those muscle fibers. Sometimes it is very deceiving, and you will be wondering when you have a disease here, which is the facial now and which is the tensor tympani. So, only one thing is, if you can identify that cochleoform process indirectly, the facial now here, the first genu should be above that. It cannot be below that. Okay, I don't know about anomalous this thing. So I am just drilling everywhere here. Okay. What happened? Patient now, if a patient is injured or post-operatively, the patient develops calcium, how do you manage? No, injured where? Like in the, like even when we are doing basic procedures. No, I know injured where? Which vertical segment, horizontal? No, if it is injured vertical segment, unless you're transected through and through, you have injured a bit, brushed a bit with the sheath, you just make sure that you decompress, open the sheath and then decompress and leave it. Okay, and it will recover. It will recover. Okay, but if you cut through and through, then you will have to cut it and you'll have to use the nerve grafting. But the nerve grafting results, it takes some time. Immediately the patient will go for a grade 6 facial palsy as soon as you cut. So best is to avoid injuring. But yeah, there are situations, because I will tell you, sometimes the cholesteatoma is such that it will pull the facial nerve up. The landmarks are in a cholesteatoma case extensive, the landmarks are distorted. No amount of anatomical knowledge of yours is useful, but sometimes you may always get some googlies. So then you will have to be very careful. You will have to take some patience. Basically, I think these are the situations where the facial nerve monitor is very useful, because I can tell you the facial nerve monitor saved some of the facial nerves recently. I mean, otherwise also we could identify. The second thing is that you have to have patience. When you know that this is the area of the facial nerve, you will have to take some time, go around doing the rest of the work, come to that work later, and then use a blunt dissection with a cotton ball or a gel foam, and then you please preserve the facial nerve. Sometimes it will be lifted. Suddenly don't drill without seeing. Okay. I mean, maybe sir is a better person to tell about. One ನಿಮಿಷ ಸ್ಟ್ರೈಟ್ ಇಟ್ಕೊಳ್ಳಮ್ಮ.
Develop small subsidiary of the muscle, but it avoids everything was detached. Previously, cortical muscle and whatever he had, everything just simple muscle, but he developed post-operatively after 2 to 3 years. Now we find that he's doing the area of him was
ಇದರ್ ಕೊಡಿ. ಇಲ್ಲಿ ಹಾರ್ಡ್ ಇದೆ. ಐ ವುಡ್ಲಿ ಡ್ರಿಲ್, ಮೇಕ್ ಎ ಹೋಲ್ ಅಂಡ್ ಕಟ್ ಇಟ್ ಲೈಕ್ ದಿಸ್. ಇಲ್ಲಿ ಏನು ಸಾಫ್ಟ್ ಟಿಶ್ಯೂ ಇಲ್ಲಲ್ಲ ಇಲ್ಲಿ. ಸಿ ಇಲ್ಲಿ ಸ್ವಲ್ಪ ಇದೆ. Give me a scissor. See, other thing is that in case you have a doubt, I am sure in case you have a recording system, please record and then you review your surgery, what you have done, because that will tell you whether you cut the facial nerve or not. So tooth forceps. So you just review what has happened during surgery, then take a call on that. Sometimes the edema also in a prolapsed facial nerve causes palsy, and usually we know that we are not cut. We tell them it will recover in 3 weeks. Usually within 3-4 days only it recovers. So this is a itkollamma tight again. This boy, give me a sharp cutting burr. No, see, this is what usually I can drill. It's believe me, this bone is really hard. And so what I do, this is basically I wanted to show the steps in see, now I'll orient you what is important. Yeah. See, now wash, please wash here, Madi. See, now you see here, this is the cochleoform process. You agree with me? Yeah. And anterior to that will be your, yeah, one minute. Yeah. I'll show, sir, 1 minute. So I wanted to show what I do. There's no point in telling something. And see, I sometimes here, when I want to remove the anterior canal wall, no. One of the important steps in a glomus tympanicum or tympanum mastoid, believe me, they are very notorious tumors. So one should be very when you're doing. I mean, you should always plan for a wide approach. Don't try to minimalize the approach. Okay, whatever said. Ultimately, what I have never seen, for example, the previous, and I have never seen facial recess being used in group O to remove the glomus tympanum mastoid, because yeah, canal wall down, because you remember the risks of damaging important structures is more. Then no, if you, it doesn't matter if you preserve the facial, you do facial recess or you do canal wall down. So one of the yeah, yeah. So one of the important thing is is that drilling the tympanic bone. Last time we have a case. I mean, sir, how much of bleeding was happening from this tympanic bone till we removed the last bit of bone, because basically I was telling my PGs, like, it was as if somebody had kept a pipe behind the bone, no, and made holes in the bone. The water, it keeps flowing like that. So the drilling, but you saw how later it became all dry. So the tympanic bone drilling is a very important step in surgery. Many a times I have drilled this tympanic bone in glomus also and removed the styloid. I open the neck like this and I keep the styloid till the end, because the styloid bone protects the internal carotid artery. Basically, under the styloid bone is your internal carotid artery. So I literally, actually, I have videos where I have pulled the, this is actually the base of styloid, and base of styloid. That is a very important piece of information. Yeah, base of styloid. Yeah, internal carotid artery is the styloid is like recently also. In fact, I'll tell you, see, we all read parapharyngeal space, deep lobe tumor, what do you call posterior parapharyngeal space, pre-styloid and post-styloid space. Yeah. Recently, I did a parapharyngeal space going into a tumor going into skull base in a pre-styloid compartment. Such a solid rock hard tumor I could remove completely. And you know, I first time I understood when I opened the neck like that, the styloid, the whole tumor was medial to the styloid. So till the end, it was a trans-cervical approach I did. I kept the styloid, and under the styloid was that carotid artery which was entering. I went till the foramen of the carotid artery going into the temporal bone. The last, though it was putting your finger was sharp, styloid, you know, the skull base structures are sharp there. It meant I fractured those styloid only at the end. So till then, I was so safe to cut anything above that. Now, when the vision is dark, so styloid is a very important. That's what, there are structures like when during my PG days, I thought why this styloid, and except for trans-tonsillar styloid excision and the digastric muscle, I thought were nonsensical structures. But believe me, today in skull base or in otology, this the styloid and digastric muscle also, be it in parotidectomy or something, it is such a useful structure, very important structure actually, styloid. So I just want to show you. See, please hold the bone tight, pa. So what I do is, whenever I want to remove the anterior canal wall, like I always, as I said, in skull base osteomyelitis, many a times the capsule is involved and there is abscess in the capsule. I have had patients who had trismus due to the disease. So the capsule of the TM joint capsule. So what I do is, and also to have a better anterior control. So one is drilling the styloid. This is important. Okay, couple of times I pulled the styloid like this, put it in the neck and removed it through the temporal bone. So this is the base of the styloid. Nah? We can probably feel it here. I will. We have to cut the soft tissue here. So now why I'm saying is, no, sir, the tympanic bone continues as a styloid bone. So that's simple as that. So the whatever I drill here, when you will see, honestly, you see where you do in a translab infratemporal fossa, I put retractors in the neck and I retract. Yeah. So as soon as I retract all the soft tissue, many a time because of the tumor infiltrating here in extensive, this whole area becomes brittle. Honestly, you use a bone, you use a nibbler, it comes off. Okay, you'll see the styloid bone. So only thing is that styloid is attached to those muscles at the tip. So it doesn't come. So sometimes I usually have pulled the styloid and drilled it to cut rather than going, because I'm worried about the carotid down. So basically, because you open the styloid, then the whole area opens up. You know, that small removing that styloid bone towards the end, makes your vision over the carotid and the bulb. What yesterday somebody was telling, jugulo-carotid spine, it gives you that so much of space. It just literally opens up that skull base like this. As you reflect the digastric muscle and pull it down, how you will open up those IJV and the carotid. Similarly, it will just open up that internal carotid artery area. You understand, no? Yeah. Ultimately, you have to dissect out the tumor from the carotid artery, or at least close to the internal carotid artery. Yes, sir. You are in the media, you are yes, sir. From the middle ears, you're talking about mid. No, sir, that's what I. Yeah, see, just give me a elevator. I'll remove this anterior canal wall bone. So basically, this is a very hard bone. I cut like this and use a monopolar cautery and then remove this anterior tympanic bone. So this whole area is a styloid now. Okay. Because I drilled the tympanic bone. Okay. So the tympanic bone actually is basically from the styloid bone only. Okay. The tympanic bone is from the styloid bone only. So this is actually, you will see here. Now I'm going into the neck here. Okay. Neck here. Okay. Neck. So here, if you feel, I am not able to feel the styloid. I think it's broken there. Okay. But this is definitely this whole area is base of styloid. Okay. This whole area is a base of styloid. This is the anterior canal wall. So I wanted to show you how we remove the anterior canal wall. Give me a blade or something to cut this off here. Because see, sometimes we are just going to talk about infratemporal fossa A. If you want to do a type B and all, we have to retract the temporomandibular joint. Understand? Retract the temporomandibular joint. That gives you a space. It is so. A couple of times I've called my head and neck friends. When you're doing subtotal petrosal and skull base osteomyelitis, I remember one case where I did a condylectomy, but my head and neck friend did the condylectomy. Okay, because I just exposed this. I opened the capsule. He came and then did a condylectomy for me. So condyle is not here because it's an osteomyelitic condyle. So we did it. So we palpated the mandible and did. So, but recently also a lot of cases. Believe me, one area, even if the carotid canal is not involved, TM joint capsule is always involved. And when you open, see, this is a capsule area. When you open like this, you will see the thick loculated. Yeah, thick loculated. Give me that bone nibbler here. Yeah. Give me that bone nibbler. Actually, there is soft tissue here. No, so this is not a capsule. This is the anterior canal wall. This is the area where I'm just taking out the anterior canal wall. So what I do is, once I take out this anterior canal wall, because I make two cuts like this quickly and take out, and see, again, each case is different. So then I use a monopolar cautery here in this area, see, and then take out this anterior canal wall. So I keep this step towards the end, especially if I'm drilling the carotid. I only thin because I don't want the fat and the capsule to protrude into the tympanic cavity. Then it causes a nuisance. Here, I think that problem will not have. Give me the drill. Yeah. Still, we are not taking the capsule of TMJ. 1 minute, sir. That is only capsule. This is only capsule, sir. Yeah, that's only capsule. Because after this, you'll only get the capsule and then you'll get some fat. So I'm just going to drill all that. I'll show you once you drill this how much control. So this may be even required if you are doing a tympanomastoid glomus. If it is going way anterior, this may be even required to do this tympanomastoid glomus. Because ultimately, what is the whole? There is nothing like this. There's no rule. It's just that you are drilling. You drill how much ever you want exposure, taking care of the vital structures, that is facial nerve and the carotid and the bulb, and you remove the tumor. Okay. Other day also we saw. I always find tympanomastoid glomus going into the eustachian tube orifice. Yeah. In fact, last 4-5 cases, not a single case there was without tumor in the eustachian tube orifice. You will have to pull it from the eustachian tube orifice. It usually comes out very nicely once you hook it. So give me the fracture, this thing, bone nibbler. After this type 2. Yes, sir. Now you are actually demonstrating type 2, isn't it? What procedure you demonstrated? So I just demonstrated lateral temporal bone resection, and I just did in that invariably we did canal wall down also. And I just did how to do a anterior canal excision, canal wall bone excision or drilling. Plus I drilled the styloid bone because see now you look here. I mean, anybody will tell that this is the carotid canal. Okay, this is a carotid canal here. This is a carotid canal here. Okay, no doubt. Sometimes we find such cellular mastoid. This is the carotid canal. So see, my removing of this gives me so much of space to drill here. I know this carotid canal is running here. It will come here. It will delineate that. But I can definitely drill when I'm going to the clivus. If I drill this area, this is the area of the clivus, where usually your skull base osteomyelitis, the abscess goes medial to that. I have n number of videos. Literally, I can just when you drill this and you'll see that pus pouring out. Now in this is a step where for an infected case, skull base osteomyelitis, of course, you don't want to injure the carotid. So this is one area where I'll be very, very careful. So this is one area of concern also when I'm drilling. But usually many a times I've retracted the carotid artery like this from the carotid canal, and then I kept on drilling with elevators. No, 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 not in skull base osteomyelitis, but in tympanojugular glomus, yes.
Otherwise, you want to
No.
keep the next ribbon to the carotid in case of bleeding.
Sir, in skull base osteomyelitis, no, not necessarily. Even if you keep, I mean, if I'm not exposing the neck, I will not be able to do it also.
Okay.
But I will be, sir, the carotid, and luckily, I'll tell you one thing, God has blessed the carotid with a very tough periosteum.
Correct.
And it is not easy to open unless some adventure. Second thing is that please use a diamond burr, coarse diamond also. Even if you make, I've seen once, if you make a small rent, you can plug it. But don't use something like a sharp instrument or a monopolar. I mean, that is a bipolar or monopolar. That is a danger. It's okay if you drill with a diamond. You can even do sharp dissection with a scissor. But don't use monopolar in these areas. I mean, that is, now bipolar is okay, not monopolar. Scissor, putting. So this is the carotid canal. We'll show you. I'll show you how I literally I have videos where we retract that.
And we are also in the relationship to the infected.
Yeah. One more important thing, they say why that carotid artery, no, that cochlear implantation goes wrong and goes into the carotid canal. I'll show you exactly. The small scissor, boss. Yeah. So you have to understand.
Electrode goes into the carotid.
Yeah. So why am see now there is. I'll show you. This is just again some tendon here. So the eustachian tube orifice, very important landmark for you. Honestly, I'll tell you again, eustachian tube orifice. Earlier and all, we thought why we should read about eustachian tube orifice. The commonly asked irritating question for MS students. Eustachian tube orifice was a pain. So, but now believe me, eustachian tube orifice is your lifesaver. So because under that, believe me, invariably, always there will be carotid canal. See here, eustachian tube orifice. Yeah, that is why they say, give me iris scissor, give me that small scissor here. That's why we say, I always do whenever I do tympanoplasty or mastoid tympanoplasties, I always flush the eustachian tube orifice with a suction cannula. I flush saline. Okay, even if I'm doing local, I just put and say whether you got water. Just I want to flush for patency of the eustachian tube orifice. Okay, I'll show you if you want. So give me that suction. But one thing you have to make sure, because I have seen cases where there is a dissense of the carotid canal. So don't use a sharp instrument without knowing inadvertently. Give me suction with the syringe, no?
Just the strokes from the micro instrument like sickle knife.
Yeah.
Strokes on the carotid, can it open?
Not easy, sir. Not easy. Not easy. Because as usually, I mean, very rare to have. See,
Yeah.
we always put and flush. So this I call it. I always tell my people. See, why we are, if you are getting good results in ear surgery, it's not because you are, I mean, we are great or something. But I feel it is because you address every aspect of the middle ear cleft, additus, antrum, and selection. The cases were also like that. You flush the eustachian tube orifice. You made sure that as Shreyas was telling, aversion system of bone. You did a canalplasty. You got that good vascularity. Cleared all that meningitis. And then I use extensively bipolar even in COSM cases to clear all the meningitis. And then you kind of you do a good grafting. Make sure that graft is lining all around. I will tell you, never it can fail. Okay, so this even the pus, many times you have removed air follicles, even sometimes some small wooden particles, insects. When you flush the eustachian tube orifice, we always flush it like that. Just remember there is a carotid canal underneath. So that is a
Routinely flush at the end of the tympanoplasty?
yes, sir, always, sir. Generally, I always flush. So now see, as I said, I'm going to drill eustachian tube orifice. Now, see, this is a carotid canal.
Yeah.
So now the important point, see how that carotid sheath is already open. Give me diamond bar. Let's do what I preached. So this is before I'll definitely identify the carotid. See, I'm drilling the the tympanic bone. Okay, give me diamond bar. See the bulge of carotid. So
Yeah.
one instrument, sir. Other day also I told you just to that carotid Doppler. I think is a very useful instrument. So because it really helped, because as I said, I did a revision Petrus apex cholesterol cyst, which was operated initially anteriorly by somebody, and patient had again recurrent cholesterol cyst. I tried to go infralabyrinthine, but I found the bulb very high. In fact, I just punctured the bulb, but I quickly sealed it. That was not a problem for me. Then I went infracochlear. This is the area. I'll show you it before I do the carotid canal. Okay, I went. This is the cochlea. You see, this is a basal turn of cochlea. You all agree? The audience. This is the basal turn of the cochlea. This one.
Yeah, road window.
This is the basal turn of the cochlea.
Correct.
So cochlea.
You identify basal turn because of the round.
No, sir. Round window is there. No, sir. Yeah, because of the round window itself. Yeah, round window itself, and also the prominent bulge. Give me a very small this thing here. Idukodi. We'll see. Because I will now open for the Petrus apex. This thing will show that. So this is an infracochlear approach to the Petrus apex. So before you do, see now even here, because I had drilled so much of tympanic bone here, only it becomes life becomes easy. Otherwise, you will be like tympanic bone, you will not get space. I did an infracochlear. Now I'll try not to open the carotid basal turn of the carotid. See here, and you have to understand below the round window niche, sometimes we have something called, see these cells, infracochlear canaliculus, correct? These cells. So people wrongly understand this cell to be a round window and try to push the electrode here. That is when they go into the wrong areas. See, now I have not drilled the basal turn yet. I know anteriorly is the carotid artery. Here is the tympanic bone. I am safe. Down is the tympanic bone. Here also I am safe. Yes, you have to be wary of one structure which comes here. See here, look here. What is that? That is the jugular bulb. I am going here. If I drill here, infralabyrinthine, okay, retrofacial, infralabyrinthine, labyrinthine block is not there. Retrofacial, I can enter this area here. Okay. Only thing, careful about the jugular bulb. See, now I am going to open into the Petrus apex. It is going to give way. You will see that yellow colored straw like fluid coming out whenever we decompress. And later, once I open, then I drill the rest of the cochlea to get a wide. Can you hold like this, please? Yeah. Infracochlear approach.
So infracochlear approach anteriorly, the boundary the anteriorly the
Carotid artery, yes, carotid artery, carotid artery. Yeah, this is, we are very clear that there is carotid artery here. So remember like this, C for C, cochlea, and C for C, C for cochlea and carotid.
Yeah.
And vestibule, and I think so. This is C for C is very important, believe me. And this is the Petrus apex, which will go. And only thing, you should be careful about the bulb. So you have not yet breached the basal turn. One more important thing I want to tell you, the distance between the basal turn of the cochlea, the distance between the basal turn of the cochlea here and the carotid artery is between 3 to 5 millimeter.
Okay.
3 to 5 millimeter. That is the distance. And that 3 millimeter or 5 millimeter makes a huge difference to me when I'm operating. At least that is what I realized. I mean, I initially thought it is just a stat, 3 to 5 millimeter. It's important to know, because if there is a, say, this is a classical example when what I'm trying to do. If it is a 5 millimeter carotid, I get some more space here to drill, which is very important. You will understand how much it is important in a tympanomastoid glomus or even in skull-base osteomyelitis, because we always want to be little away from the carotid. That is the whole, that is the mindset. I mean, nobody is there bold enough to say that I'll puncture carotid there. Okay, so this is the Petrus apex. I've already gone into the Petrus apex. This will definitely, in fact, we are under the carotid and under the cochlea. So this is the, if you do like this, definitely you will get that yellow fluid. Yeah. So this is the Petrus apex which I opened here. Petrus apex cell. So this amount of opening might not be enough. So obviously you will have to complete drilling the whole cochlea. So that forms other thing. Right now, what we'll do.
According to you, even the cochlea has to be drilled out.
Yeah, better.
So patient will develop that here.
Yeah, if I mean hearing is not there, in case hearing is not there, it is good. If hearing is there, then I think it is we can probably leave the cochlea. Not always. See here, I have drilled for the carrot. So how close it is? Okay, thick sheet. Okay, I'm using a diamond burr. Since I'm using a small diamond burr, and see here, it has become little dried, so it will open up. That is the thing.
Have you opened the carotid?
Right.
Carotid, you can open.
Yeah, I'll show you, sir. Now I opened it. Looks open. This coarse diamond is really good. Huh? So yesterday somebody was asking about the crotch. You'll see the crotch. This will be the crotch. Give me elevator, round knife, and I want a. See, you understand now why important to drill the anterior canal wall. So you got so much space. Okay. The same carotid. See, one more important landmark. I said about the basal turn and the 3 to 5 millimeter. So one more important landmark is your GSPN. So give me a small round knife elevator, boss. The GSPN here, that I'll show you when I'm doing the posterior rerouting. So I think first we'll do anterior rerouting and then we'll do posterior rerouting. So then we'll drill the okay. See here. Now this is the carotid wall. Exactly what I told many times. Give me micro elevator plus flag knife putty. I literally elevate this carotid artery like this, and surgeries. I can show you the videos where I've done like this. Yeah, where I get little worried is when it curves above. Because here I'm not worried because I know exactly where I can find a vertical segment. Okay. Give me, yeah, vertical segment, petrous carotid, once it has entered the temporal bone. Give me iris scissor, boss. That is irritating here. Here you always will have some tough tissues which takes some time to clear. No, you can only do sharp dissection. Clear. Okay. So the GSPN, see this is a GSPN here. The GSPN will come, which will run parallel, to the. It's a very good landmark for a skull base surgeon for the horizontal carotid. It runs parallel to the carotid canal, horizontal carotid. So this carotid, which is entering the petrous bone, comes like this, goes like this, curved horizontal, runs like this. You have the middle meningeal artery and all that. It goes to the lateral wall of the sphenoid sinus. I've done dissections where we've gone from here to sphenoid sinus and then enters there into the cavernous segment. So this is a vertical segment, becomes horizontal, goes anteriorly, and then it becomes again in the cavernous segment, and then it goes intracranially. So once you identify the carotid, I'll show you. See, I can drill anteriorly to that. Exactly what I said. So this is a challenge in a skull base osteomyelitis. So I do hope sometimes there is no disease there and other areas are there which I address. Nowadays I don't unnecessarily open all the cases in this area, but a lot of cases you will have to do this in case you will have to decompress this area. Believe me, so much of pus comes out through this area and that relieves the pain. Okay. But one thing is that this is a normal temporal bone, but in a diseased temporal bone, the disease itself will provide you help to dissect. That is always so easy. When we have a disease in the sinus also, the life becomes easier than operating a normal sinus surgery. The same thing here. When you have a diseased temporal bone, that makes life. This is a clivus. What I'm drilling is a clivus anteriorly. See, I can drill to the clivus and go anteriorly here. Yeah. Yes, sir. Yeah, but of course, we opened a carotid, which should not happen because this wall will become brittle. It's not like normal. And also, we are trying to be a little fast. Not centered? How, sir? Yeah, this is the clivus, sir. Medial to the carotid. See, I retract like this, and then this is the clivus here. See, all the way you can drill. That is the only way you can decompress the nasopharynx here. See how much space is there. My problem starts when this carotid curves here. When I have to drill here, I get little this thing because this becomes like a little bit of a blind area, the genu area. This is when it turns, it is called as a carotid genu. horizontal genu of the carotid, okay, which follows the greater superficial petrosal now. So I think we'll stop it here in this particular drilling, because there is no bone there or anything for me to drain. And so this is, but you see how much of bone I've drilled, and see how much space is given between the carotid artery. Yeah, see so much space. This is actually, this bone is very spongy. Okay, as you go here, see, it's like how I did the jugular bone. This bone becomes very spongy. So you drill here, you go into the clivus. So you saw the carotid artery here. So how close the carotid artery is related to your basal turn of the cochlea. So 3 to 5 millimeter is the distance of the carotid artery from the basal turn of the cochlea. So be careful about this movements. So this is the carotid artery here. And now what I want to do is that, so we will do anterior rerouting, because posterior rerouting is easy. Anterior rerouting. So
brief up what all you have done with the artery. So what all
yeah, jugular bulb is here. One thing is very, yeah.
You showed us trans lab.
Yeah.
Identification.
I'll show that.
Yeah.
I'll amputate this because we have the patient. We'll amputate the tip. It's unnecessarily going to consume time. So basically now, see what we have done till now. See, now we see how much we have drilled the bone further. Yeah. So give me an elevator or something, boss.
No, we can't say that it is temporal bone.
You give me the elevator.
We don't know.
See, this is a temporal bone. So first thing I did, I'll reduce the magnification to further less. 0.4 is there. Yeah. See, first thing is that I widened the approach. This is the first thing. Then I identified the digastric so that I could identify the facial now here. So nobody can dispute that this is the digastric ridge here. Yeah. So this is a nice pneumatized here. I drilled all the bone here. See here, the sigmoid sinus. See, even for me initially, see sigmoid sinus. This is all cell. Let's not waste time trying to clear this. It's not like how in real. So you see here, if I try to remove this bone, this will give way. This is the bulb. See this?
Yeah.
You're seeing this? This is a bulb, jugular bulb. You see that bluish jugular bulb here.
Yeah.
Okay, so that's what I said. If you want in a acoustic also, we can displace. Like for example, if the bulb is bleeding, so I do the same maneuver what I'm doing here. Look here. Okay, I can maneuver and put some surgical there and bone wax and displace it a bit here. You may ask, why are you doing this? No, it's not, because believe me, giving a little bit of space helps me to remove the bone here. In a wide approach where you want all around the internal acoustic matters dura, it gives you a lot of space. So that is the whole concept of philosophy of drilling. Okay. So see, now I can disclose the jugular bulb. It will not cause anything. It may lose a bit, but you can always put surgical and stop. Don't puncture it. Don't use sharp things. Don't use monopolar cautery. Don't use sickle knife and all that. So this is a bulb. So we can even go. Give me the drill here. We'll go from the infralabyrinthine or retrofacial. Give me the drill. Retrofacial. Okay. See, I could do, we could only do all this because I've done dissections. But there's no shortcut to it. And I think I've dissected and observed keenly when others are doing. For me, if you ask somebody, ask me, I tell this to this thing, 50% of the surgery you do is observation. So you learn surgery by observing. Nobody will make you do an infratemporal fossa approach or by holding your hands or doing a pituitary. First you have to observe, then you do dissection. And 50% of the surgery you learn is actually through observation. So you have to have keen observation. Of course, you have to observe the right person. That is obviously there. So actually, I should have gone here. This is little bulge and hard bone. See, infralabyrinthine, we can go into the petrous apex here also. Okay.
What is the exact point of entry for infra?
Sir, infralabyrinth, basically identify the bulb, identify the facial now, and you will have the posterior semicircular canal here. Yeah. Don't touch the posterior, you go in that angle here. Okay. So for that, the bulb should not be too high. Okay. That is a contraindication. Very high bulb, sometimes, see, that's why when you do an MRI, see, whenever we are doing this skull-based tumors, important is to do an MRI contrast. In MRI contrast, in the coronal section, you see for the dominant bulb, which is the dominant bulb. Most often, right is dominant. I mean, sometimes it is same, but what I'm saying is sometimes there will be one side bulb which is totally atrophied. In fact, that is one of the contraindication to do a glomus tumor surgery. There's only one dominant bulb, and that is involving by the tumor. You're not supposed to. I mean, one contraindication happens because it leads to cerebral edema. That's why you do an MR angio and MR venogram always. Okay. So that will tell you in the coronal section how high is the bulb. So that also decides your drilling in a translab plus all these things. What I'm doing when I'm saying that the bulb is high or bulb is low, you decide by imaging. You decide not that not intraoperatively but before surgery itself. Okay.
There's a question here.
Yeah.
How not to give the facial nerve?
One is that you should be careful about the shaft of this. Okay. Shaft of this, keep observing.
Or should we
irrigate
the nerve before doing it?
No, I am not doing it for the sake of remodeling. I am not. I am just. This is just. I'm drilling for the Petrus apex and this thing. Yes, we have to reroute the. If I have to excise the bulb, I have to reroute it. It's better. We can also do, as I said, intact bridge technique. I did a case. I will show you. And I have a video of that. But that was one isolated. We don't get that anatomy case. So now, see, we are supposed to, before we reroute, we identify the facial nerve and we dissect the facial nerve till the parotid segment, bifurcation. So now, so we identified the carotid, the eustachian tube orifice, we identified the clivus. Now, without wasting time, I would like to fracture this master tip. Okay, master tip, because this is not going to help us in rerouting here. So give me, this is always which I do also before surgery sometimes. Even this step is used in case of you want to do a cholestoma case, which is going extending inferiorly. You amputate the tip of the mastoid. So before I amputate, see, basically at this stage I would have drilled so much that the whole thing has become so thin. All you have to do is just do this. Even here it's a little more thicker and hard because I didn't amputate, but I would have drilled so much that the whole thing will just come. And then I use a monopolar cautery and free it from the muscles in the neck. Give me the drill. Here it's a rock hard actually. Cutting ದೊಡ್ಡದಿದ್ಯಾ? I'll drill some more so that ಅದು ಇಟ್ಕೊಳ್ಳಿ. ನಾನು ಇವಾಗ ಬೇಡ, ಇವಾಗ ಅದು ಕಟ್ ಮಾಡಿ ಗುಡ್. ದೊಡ್ಡ ಸೆಕ್ಷನ್ ಹಾಕ್ಬಿಡಿ ಅಮ್ಮ, ದೊಡ್ಡ ಸೆಕ್ಷನ್ ಹಾಕ್ಬಿಡಿ and just hold this temporal bone holder. Okay, leave it. Hold the boulder. This is the tendon. Okay, digastric tendon. So when you know the digastric tendon, you stay above that. Nothing to worry. Only thing is when you're drilling like this posteriorly, here you get some occipital artery. The occipital artery we always divide in doing a glomus tumor. So that occipital artery, you be careful, it will bleed a lot. So you just have to clip it with a Liga clip or something. It's a very, very hard bone. It's very hard. Aita, please hold it firmly. Thin it to make it pliable. Then see here what exactly I told. Here you got the muscle here. So amputation of the, one more thing you have to remember, in case you had a disease where you have to amputate the mastoid tip cholestoma, don't worry. That's not going to increase your cavity bigger. Okay. In fact, the cavity, yeah, if you keep it, it becomes like a sump. See this muscle here. So after this, so wash ಮಾಡಿ. Give me this thing to fracture the master tip now. Bone nibbler ಕೊಡಿ. Heavy scissor ಇದಲ್ಲ. Hold it please tight. Yeah. See now, just fracture it like this. Okay. This is a real hard bone. So once I usually fracture like this. Okay. You see it here, and then I use a monopolar cautery. Here you have to be a little careful about the facial nerve anteriorly. In this, give me a scissor, heavy scissor and tooth forceps. I use a monopolar cautery which will make it bloodless. Okay. And I amputate the tip. Here, see, this is a digastric. So really nothing to worry here. It's, even the muzzle is so hard. Give me a blade. So this is the amputation of the tip. See here. Okay.
I think it's we should be careful with the patient now.
Yeah, we have to be one ನಿಮಿಷ ಇಲ್ಲಿ ಮಾಡ್ಬಿಡಪ್ಪ. ಇಲ್ಲಿ have to be careful. In fact, when I am rerouting, I keep a cuff of tissue, that is the digastric muscle, attached to the facial nerve. Okay. Here we don't have the parotid segment, so that is the thing. Bidi ಇಲ್ಲಿ the facial nerve bidi. I'll dissect it for you. So give me a fractured bone nibbler. Hold ಮಾಡಿ.
Tympanic bone.
Yeah, this is also part of the tympanic bone, sir. Inferior canal wall. Give me a scissor.
Only portions of temporal bone is disturbed.
Facial nerve is here. Okay, I've already identified it. Okay. Give me there's some twigs here, blood vessels maybe. Give me a scissor, on the sharp scissor ಇದೆ ನೋಡಿ. See here, this is a facial nerve here. You can identify this? Seen, sir?
Yeah, we can.
This is a facial nerve here. This is a facial nerve here. Okay. Because once I do anti-rerouting, the posterior rerouting will take another few minutes. Then we'll drill the cochlea. Okay. Drill ಕೊಡಿ. Drill. Give me a coarse diamond, smaller one. Yeah, that one. Yeah. Choose bidima. So this is again, this small things are very again important. They irritate you during surgery also. Always run parallel to the structure. The facial nerve rerouting, I'll tell you a very important trick, which is very, very important. That is, always start rerouting from down, inferior. Yeah, never try to reroute from horizontal segment. Sir, horizontal segment is thin. So trying to reroute, you'll put traction and you'll get cut.
Usually the process is
You know, but vertical segment is thick color, sir. Facial nerve, vertical segment is thick, and you also have, see, I'll show you, and give me a, ideally you should use a, this is actually, your sir was asking, this is a styloid bone. I think now it is very clear to you. Yes, I'll show you. This is a styloid bone. See, as soon as I open that styloid bone, you'll see you are sitting on the carotid artery. This bone here. This is a styloid bone. This is a styloid. It's partly fractured here. So this is a styloid complex. Okay. So give me a non-tooth forceps and 15 blade. So usually use a 11 blade. In real, I use a non-tooth forceps. Again, I hold. You should have freed the facial nerve till the bifurcation. See here. And one more thing, while drilling, be careful, because the more you drill and rub the facial nerve, it becomes very fragile, and then rerouting is going to be tricky. So first is you have to free it here. You free it here because then only you can rotate it adequately. Here I'm not going to trace this facial nerve like how I do, where we put an artery and dissect it and go till the bifurcation, and little further from the bifurcation you have to go. Okay, to identify the branches. Only then you will get a good length. earlier I lost myself while rerouting facial nerve encircled in my burr. So because that was the case, I did not use fibrin glue. One more important trick is always use
Facial nerve encircle the birth.
encircle a bit and got cut, but I later repaired it. So why I'm saying is that will happen because I remember one young student I did. Towards the end, I had done a beautiful rerouting fixed with fibrin glue. Towards the end, when I was resecting along the bulb, there was a torrential bleeding. Then the whole thing became so bloody that I had to pack it. I had to leave it for some time. In such situations, if you don't fix the facial nerve properly with fibrin glue, you will lose the facial nerve.
Where do you fix it?
I'll do. That's what I'll tell now. So just trick is ಇದು ಕೊಡಮ್ಮ ಅದು ಫ್ರಾಕ್ಚರ್ ಮಾಡ್ಲಿಕ್ಕೆ ಕೊಡಿ. Yeah, this now is a little brittle. So what we'll do is, see here, give me ಏನಿದೆ bone here. Okay, give me drill please. So basically it is a sequence of steps. Like every year surgery we have to do a certain steps. Same thing in this surgery also. Every step should be done properly for you to go to the next step. So no step is not important. So that is why if you see there is atlas of skull base surgery, there's so many steps, 14, 15 steps given. Each step is so important. See now, I always free this using a 15 blade, 11 blade. Okay. See, you should lift it from here. Avoid too much of traction. Okay. In this case, give me flag knife. See here. This is the way you free hit. Okay. Don't rub too much on the. Give me flag knife. I use once I elevate this much with a 11 blade, I use a flag knife. I use a flag knife gently. You have to take some time here because this is again. Sometimes what happens, we have a
We can expect carda branch coming up, and nerve separated coming up.
Give me that. See this. Look here. How nicely I've elevated. It is coming here.
Second link.
Yeah, nicely elevated. You are supposed to elevate it. This is already done a tunnel. This is what I do. I keep it here like this. In fact, you are supposed to elevate till the first genu. Okay, which is elevated. Now see, the whole idea is once I elevate, see this whole area opened up now. The bulb is directly under this. The bulb is directly under this, and see how I elevated the facial now. This is anti-rerouting, and I myself am surprised how I could. The anti-rerouting has given me fantastic results because young patients I operated, glomus jugulars, and one thing I want to see them is having a good facial nerve function. So this anti-rerouting has been very good. It derives blood supply from the. I suture it here. I put a stitch here to the parotid tissue. Then I put a fibrin glue. In fact, we freed some more here. I freed. Just put it on that. Just put. No, sir. It fixes like this nicely. You'll fix it like a strong, like a cement. It will fix to it. Yeah, it will be left like this. You don't have to reroute. I think one person skull base surgeon, he likes to put it back on the fat, but I only leave it. I just follow whatever I've learned in Grupo, and I just keep it like this. And amazing facial nerve results, actually. Okay. So this is.
You remove the electrical bone there.
Yeah. Now I've done this. Give me.
And if you trace anteriorly.
Yes, sir.
You come up to here. You trace anteriorly the horizontal segment, and you can show the geniculate canal.
Yeah, I'll show that, sir. GSPN, because that is now for the posterior rerouting. I'll show that.
Yeah.
So posterior rerouting. So yeah, for that you need to identify where is the first genu and the GSPN. Only then you can cut it, because you don't want to cut the facial nerve. You want to cut the GSPN.
Yeah.
So now what we'll do is we will drill off this, or we'll nibble this. Give me bone nibbler. Anti-rerouting you do for a jugular paraganglioma in an infratemporal fossa A approach. You can do for other indications also. Infratemporal fossa A approach is anti-rerouting. Okay, for a modified transcochlear approach, which is actually first time described by Sanna himself, you do actually I could not. We didn't do transotic. I'll just tell you what is trans. So I removed that bone which was just under the facial nerve. Yeah, tympan. No, that facial canal bone, sir. So give me forceps. See, had we kept this facial nerve like this, okay, in the facial canal, okay, like this, and then I drilled all this, like I said I did for one case, then drilled the cochlea, leaving the carotid, facial canal like this would be called as a transotic approach. So transotic approach. So the transotic approach, again, like we can do for Peter's bone cholesteatomas, transotic approach also for a say acoustic which is going anterior, you can drill all this and cut open the dura and dissect the tumor. Okay, anterior control. So now if I reroute this anteriorly, this is for an infratemporal fossa type A approach. Infratemporal fossa type A approach, where now my area of interest was this area. Yeah. This is the area of interest and the carotid artery. This is the crotch. Yesterday somebody asked me what is the crotch. This is the crotch. This is the crotch. This is the crotch. Yeah, this is the crotch here. So this is again developed after my drilling. This is just a piece of a tympanic bone, a jugulocarotid spine. Usually this bone is always infiltrated by a jugular paraganglioma. So it will be many times brittle. So you will have to drill that, the diamond burr. So invariably you will have to drill this much. So if at all you leave the facial nerve hanging like this, suturing without fixing glue, I understood that I get sucked into the drill, because still you have a lot of drilling to do. Sometimes the tumor also involves a carotid. Even you saw in tympano mastoid other day, partly it was involving the basal turn of the carotid which I drilled. So you will have to drill. You may have to drill all this. The idea is like there's nothing, no rule fixed. Whatever is involved by tumor, you have to drill. The only way you can remove that is by drilling only and achieve hemostasis also. So now only my concern is that it might get sucked in. So I'll put it in the intracranial cavity. So I'll do it now. I'll just show you.
When do you do it?
That is for modified transcochlear. Okay. So I just put the facial now here. So you saw how we could do anterior rerouting. Now give me the drill. A big coarse diamond I could put it.
Today you are doing very well.
Thank you, sir.
Okay.
So as I said, sir, it is because of the dissection. And in fact, this is the third time I'm doing a live cadaver dissection and demonstrating. Yes, sir. I'm just drilling the bone around that over the bulb. That is part of the, yeah, so you can call it as a tympanic bone only. Yes, you're right. Tympanic bone. See, this will get punctured. I can't help this because it is dry. So anyway, I'm going to remove the lateral wall of the bulb. See, it is already opened up, so it's okay. See, this is a styloid. I'll tell you why I said the styloid. In fact, in this stage is when I open up the styloid, and I would have looped the internal carotid artery and the IJV in the neck. IJV in the neck. Usually, I have taken time from 7 to 12 hours for glomus jugulars. Earlier, fastest I have finished once only with me and the nurse operating only in 7 hours. But I mean, it depends. Some tumors are very notorious again here, because a lot of jugular, what do you call, jugular paraganglioma, type C. Type C is what when we call the bulb is involved. Okay, give me the bone nibler boss. Yeah, this is a bulb area. Anyway, we are planning to open it. Now, what I want to show you is, see, now this is a styloid bone, right? See, as soon as I open this styloid bone, scissor putty, and I'll drill there. See how high the bulb is going. See, this is one thing which amazes me. It sometimes frustrates also, in the sense you always we see that is, we learn through experience doing cases. So initially we all want to, when you start beginner skull base surgery, so we always want the bulb nicely behind so that we can dissect. No, it is going to go so close to the carotid artery and hug it that you will get why this bulb is protruding so much. You can, there's an example here. Okay. So the bulb is, this is what is the crotch, what is telling. See, once I remove that thyroid bone, you'll see that petrous carotid coming down. And also you see here, this is the crotch. See here, the carotid artery, sir, you're seeing that? This is the carotid artery here. So see, the moment I opened the styloid, I could see the carotid here. Give me the scissor, we'll take off this muzzle here.
Carotid.
Yeah. Entering into the temporal bone. Take this. See here, this is the carotid artery here. Look here. Yeah. Carotid artery. It's in the neck. I have a two forceps. So I think one also needs to have some basic. A lot of people ask me, I want to do skull base after MS ENT, but I would recommend them to do some good amount of ENT work, neck and otology, and then jump into it because it involves multiple things. Okay, see this carotid artery, as I said, give me a round knife elevator. See, as soon as I open the styloid, just under that. So the styloid is your savior actually. Styloid saves you in many situations. At least you know, because you do get confused. This is this is the carotid artery here. Okay, see this is this bone, this unstable bone here. Give me that elevator boss. Yeah, jugulocarotid spine is what I call it. See this jugulocarotid spine or the crotch. Below is the jugula. Yeah, this is a bulb. This is a bulb. Give me elevator boss. Give me elevator and 15 bed kodi. Hold on. Give me. Are people viewing online also, sir? Yeah. Yeah. See, this is the bulb here. See how close the bulb is coming. I want you to appreciate. See, it's almost, see, under the cochlea basal tongue, it's crossing that. Okay. So we have kept the bone here. We will not do, I just resect the bulb. I'll show you what is to be resected, what is not to be resected. We resect from lateral wall like this. We'll just resect this much here. Okay. See how important to identify the bulb. Give me that bone nibbler. Bone nibbler. So all this bone, now, I mean, nobody should have a doubt what is the crotch and the jugulocarotid spine. It's a very big one here. Give me drill. So this is always infiltrated. Give me some sannadu kodi. Drill. Sannadu kodi. See, I just remove this bone. Centered. Cochlea is left there. So all this bone is infiltrated here. Okay. So I have to drill all this bone sometimes to remove the tumor. Okay. That is a must. And I just remove this bone. So why I'm saying is, this is the cochlear aqueduct probably. This is the bulb is open. Okay. Suction. Okay. So now you agree this is a crotch here, sir? What happened? Elevator. There. Yeah, I'll use this. I use a bigger one just to finish it. Elevator kodi. This is the crotch. Audience. What happened? You're there?
Yes, sir.
The crotch here. So you can just leave the crotch. Just so this is a crotch. Okay. So basically it actually condenses and see it goes into the neck now. Aita, it goes into the neck. Give me that 15 blade or something. So give me tooth forceps. Actually, we even in a bone we identify the local nose, but I don't know whether it will be possible to do it here. Okay, so this is a crotch. So now, sorry, once we have done all this, you see the whole bulb is exposed, and the tumor is involving the jugular bulb, and I can show you big bulk like it goes into the IJV. So we need to know till where the tumor is extending in the IJV. So can you give me an artery? So what we do is that artery. So recently I did a facial schwannoma case where I did not do like an infratemporal fossa A approach, like I did not ligate the IJV. I just looped the IJV, but I did not excise the, I did not cut the IJV. But what happened is I found that a tumor was involving the, I even did sural grafting, it was going up to the parotid segment. So I dissected, freed the dumbbell shaped tumor, did the grafting, but the problem was I realized towards the end the lateral wall, which was also given radiologically also, the lateral wall of the jugular bulb was involved by the tumor. So I decided to, of course, I have to remove that lateral wall of the bulb. So I exposed, not like this, but I exposed the bulb, like how I do in infratemporal fossa approach. And then I just packed. So after this, what we do is, give me artery here. So we control the neck. We control the neck, IJV, internal carotid artery, we loop it and we keep it. We don't ligate the internal carotid artery. It is only for emergency. We ligate the IJV down. We cut it. So we cut it when, just give one.
Anytime you have ligated internal carotid artery?
No, sir, no.
Nothing.
No, nothing.
Even if you ligate, will be there any?
Yeah, internal carotid artery, if you ligate, sir, they will have stroke unless you is having a good balloon occlusion test. So external carotid, I have kept it this thing, but no, you should be very careful about that. Because once I got a call from one of a colleague that while doing a parapharyngeal tumor, what happened is he felt it is EC and ligated. Patient went for stroke and coma and this thing. So ICL ligation. That's why we should do MR angiogram and MR venogram. You see what is the contralateral carotid artery circulation also.
Okay.
Oh, that is very important. Carotid artery circulation. So they'll be lucky if it doesn't get stroke. 15 blade. So just show this, all this is, we follow all this dissection. So it'll be much not crude like this. But so now I will just do here, because this sigmoid sinus, what I do, I'll just show you, because this is a ledge of bone. Give me a small gauze, ಏನಾದ್ರು ಇದ್ರೆ cut ಮಾಡಿ ಕೊಡಿ. So we would ligate the IJV here. We would have looped the IJV in the neck, but we don't ligate it. First what we do is, because we don't want a reverse flow, first we will pack the we don't suture, we do extraluminal packing. One ಸಣ್ಣ gauze piece ಕೊಡಿ. ಅಷ್ಟು ಸಣ್ಣ packing, yes. Extraluminal packing we do. I'll just show you how it is done. For that, I drill a bone and leave a ledge of bone over the sigmoid sinus. So for example, this is a sigmoid here, already there is a hole. Let's take this as a ledge of bone, because I'll just excise this much. Not centered, sir? No. Not centered this much. Okay, now it's okay. So this was a sigmoid here. So there's a bone here. I leave a ledge of bone like this. Okay, I just thin it out, leave a ledge of bone. Give me a small gauze or something. Okay, because now here it's already punctured. I can't do anything about it. Okay, leave a ledge of bone here. Okay, so give me a gauze, and give me a round knife. So what I do is, round knife. Be careful, round knife. ಇಲ್ಲಿ ಹಾಕಿ ಸಣ್ಣ ಗೌಸ್ ಕೊಡಿ, ಒಂದು ಸಣ್ಣ ಪೀಸ್ ಅಷ್ಟೇ. So we push it like this. Okay, so I don't do it, honestly this is not the correct area, because we are in the bulb area, because here there is nothing for me to show. We drill this much and leave this much bone. Again, how much you resect the lateral wall of the sigmoid sinus depends on how much the tumor is involving the sigmoid sinus. Sometimes the tumor comes all the way here, it is infiltrating here, you'll have to come till here. If tumor is only till here, you only have to take, you have to go above the tumor. Put that gauze here, man. So ಇದಷ್ಟೇ cut ಮಾಡಿ ಕೊಡ್ರಿ. So we put surgicel and bone wax. ಇಷ್ಟೇ, yes.
So here you are showing with gauze, but actually you are putting
surgicel. Yeah. So what we do is, we put extraluminal packing like this. It really nicely seals. Even if somebody you encounter while doing a mastectomy surgery, you encounter, it's went inside the suction. That is a big suction. ಸಣ್ಣ section ಕೊಡಪ್ಪ, ಹಿಂಗೆ ಕೊಡಿ. ಹಾಕಿ ಸಣ್ಣ section ಕೊಡಮ್ಮ, ಅದೇ ಹಾಕೋ.
Can't we ligate this?
Sir, sir, actually, I'll tell you that ligation was being followed earlier, not required, because that ligation you will puncture the dura.
Okay.
So better not puncture the dura posteriorly. CSF, one thing you don't want in infant. See, this is what group of philosophy. If at all there is a tumor, jugular paraganglioma, which is going intracranial, I've done that is called class D tumor. Okay, I told the neurosurgeons not to do it in single stage. I'll do the extradural. You can come back and do the intracranial later. Sometimes they don't listen, and you'll have months of CSF leak coming into the neck. Never open in a jugular paraganglioma unless it's a very small one going into the neck. Okay, you should not open the intracranial and the neck in one sitting. Okay. You do the extradural part first, then next sitting. Yeah, neck, it becomes a big problem, sir. And already the patient, idea is to preserve the cranial nerves. So see, this is how we pack the extraluminal packing. I put a nice bone wax and seal this whole area with extraluminal packing with the bone wax. So after doing this, what we do is, give me iris scissor. See, this is packed nicely. It will collapse. Beautifully, it collapse. So even in case you're doing some surgery and you got a sigmoid bleed, assume if it is just a bleed, just put a gel foam. It's brushed, put a gel foam and then put some cotton patty. If it is, you have made a hole, don't worry. Take a small Surgicel. You just keep a good suction and just push a Surgicel into that a bit by bit. Don't force through a sharp instrument. You'll put a Surgicel into that hole, suctioning, and put a patty or a cotton ball and keep it for some time. 100% it will stop. So you'll never have a problem. So no need to panic, because we have had situations where juniors. Once I was working with an AIMS fellow, PG from AIMS. So he punctured sigmoid and then he didn't know what to do. Next, he just left it to bleed. And was told, go please at least put a patty or a gel foam. So why I'm saying is, so that is very important. See, now you resect the lateral wall of the sigmoid sinus, and then you excise the bulb of the sigmoid sinus, lateral wall. Okay, and down I would have ligated and divided, sir. Okay, down I would have ligated and divided the IJV. Yeah, ligated and divided. So this will be till I would ligate there till where I can feel the tumor a little bit down. See this? Now the medial wall of the sigmoid sinus is preserved.
Yeah. So
okay. Yeah. So that it's here all dark here. Wash kodi ili channage. Yes, sir. This when you do this, invariably there will be a lot of bleeding.
Yeah.
There will be bleeding. You just take a Surgicel. Give me a gauze. See, this is all from the inferior. Usually, it will fill up a bit. Again, no need to panic. As long as, see, one philosophy, as long as you're not injured the carotid, one need not worry.
Okay.
Whatever bleeding happens from the bulb, everything you can stop. Okay. See, I've removed the whole clot. See here, this is the inferior. So you see a sinus here?
Yeah.
This is the inferior petrosal sinus. And see, this is a little, as I said, it's a little dried up bone. If I lift up this, you will have the cranial nerves. Give me something to fracture. Cranial nerves under the medial wall of the jugular bulb. Okay. Sorry. Give me the other one, boss. Medial wall of the jugular bulb, you will have the cranial nerves. So I have seen most of the cases, I have been able to preserve the 10th cranial nerve. Okay, that is very important. Again, because then patient will have morbidity, has to be put on Riles tube for some time. Especially older patients don't tolerate cranial nerve palsies. Younger patients tolerate. Older patients, till now, I don't remember any case where I had a jugular 12th palsy, but unless it has come, I had few cases where already the nerves were paralyzed. Somebody told me there's a case, 26-year-old girl, but with all cranial nerves paralyzed. So this can happen. So that is one of the reasons these tumors better done earlier stage. It's less painful for the patient as well as the surgeon. So this is the extraluminal packing. I already done. You pack it over the lumen. Give me scissor. See this medial wall of the jugular bulb, sir.
Yeah.
Medial wall of the jugular bulb is seen, and give me that scissor, and we'll take off this bone.
So routinely one need not remove the medial wall of the.
No. We always preserve, but sometimes what happens is there will be some tumor sitting on that.
Yeah.
Medial wall. It depends, sir. Again, it depends. Some tumors I find a very kind of infiltrative kind of tumors. This is paraganglioma. Some are.
The tubular bulb is nothing but a dura. It is a part of dura,
Yeah.
isn't it?
Yes.
Technically speaking, it's a part of dura.
Yeah. So you can just this thing and just pack the whole inferior petrosal sinus. You can keep a broad suction and you can pack it. It will stop. Okay, nicely it will stop. And also one more thing, while packing, you make sure that you don't pack too much Surgicel.
Okay.
Because the packing itself will cause cranial nerve paralysis. If you put too much of pressure and pack it nicely, give me that bone nibbler, then that itself will cause.
No, you have packed it much above, isn't it? You have packed it almost at the sigmoid sinus.
No, not this packing, sir. When we pack the inferior petrosal sinus, sigmoid sinus, that I did extraluminal packing.
Yeah.
Bone wax. Yeah. Then when this, yeah, when we remove this, when it, yeah.
No point. There's a.
No, this will still bleed, sir, from the petrosal sinus. It will bleed quite a lot, in fact. This bulb, when you exercise, it will bleed.
Then you pack, no? There's nothing to hold the pack, isn't it?
No, nothing to hold the pack. It just stays in its place.
Okay.
That's all. Pack just stays and seals. Only thing is, don't pack so much because under this, you have the cranial nerve, sir.
Okay.
See, I'll tell you how the ninth goes like this. The 10th comes like this with the hypoglossal like this. The 11th spinal accessory comes like this. Okay, spinal accessory comes lateral. So the spinal accessory is identified. The 10th is also identified along with the 10th and 12th are identified along with the carotid artery when we are looping the carotid and the IJV. But 9th generally we don't go to identify. 9th is also very thin. Okay. So basically you pack enough so that to stop bleeding. Don't pack overzealously, pack too much. Okay. So now we see the sigmoid, bulb, carotid, and this is all the bone, petrous bone, and this is interlacoustic meatus, and this is just the cochlea left. So now here, what I'll do is I'll drill, and we have done infratemporal fossa approach is over.
So now you have just the brief of what else.
So till now we started with widen the exposure. We did a translab approach, and after doing a translab approach, we did lateral temporal bone resection.
Yeah.
We did drilling of the tympanic bone and the styloid bone.
Yeah.
Then we did approach to the infracochlear approach. Then we identified the carotid canal, only the vertical portion of the carotid canal. In fact, we identified where the carotid artery enters the temporal bone here, or temporal bone, and then we removed the anterior canal wall. Then we rerouted the facial nerve anterior so that we could go to the jugular bulb. Jugular bulb. This is a classical infratemporal fossa A approach. Removed the styloid so that we could see the carotid, and we have achieved hemostasis by. Sir, B approach is you'll have to follow this carotid anteriorly, sir. So no. Yeah, we've just finished, and I think we'll. Transotic, I already told, sir. If the facial nerve was here like this, I drilled this and I drilled this also, that would be called transotic.
Okay.
Since transotic approach was the first which was described by Hugo Fish.
Okay.
Because Prof. Sana found that restrictions, because when you do a transotic approach, the facial canal will come here.
Okay.
But yeah, facial nerve functioning will be a little better. So it will still limit your access to the area where you want to go. Petrous apex anterior part of the CP angle brainstem. So that is when he designed the modified transcochlear approach. Now I'll show you that modified transcochlear approach. What happens that already we have rerouted here. Only thing is in modified transcochlear there are different types A, B, C, and so I am only going to tell the A type A, which is what I also have done and I have experience with. So that is the posterior rerouting of the facial nerve. See now this is a cochleoform process. Cochleoform process. See here, this is a cochleoform process. Facial nerve goes above that, and this is the canal of the tensor tympani. You see here, this is a muscle. Clearly make out it's a muscle. Give me a scissor, not centered. Sorry. Higher magnification. Better. This is okay. This is better. Yeah. So this is this thing. So
Very clear.
yeah, muzzle, and then you have the this is the canal of the tensor tympani, canal of Huyer, chorda tympani also. Give me drill. So now you see this is the area.
You just mentioned exactly.
Yeah, actually it goes here only, sir.
We have to just exit anteriorly. I think it is now. It is usually along both of them run together. They say parallel, and sometimes it is they run. I mean in unison, ear and muzzle. So give me a drill. Now the whole idea. Now we are drilling. You see how much sound that coding.
Now you are actually going to see the delineate ganglion, GSP nerve, the V bend and the labyrinthine segment of the all these things.
So now we have to drill above that. So we know this. See, this is also important in cholesteatomas. You see many cholesteatomas which are involving attic. Invariably, they will involve this area. I mean, I would be surprised if it is not involved attic cholestoma. So one of the important step is drill here. Everybody, we all, whatever we are, like we will be scared of obviously facial nerve only. Okay. So this you should know when you're drilling here. Sometimes because we have the foot plate here. See, foot plate is still here. I think so, right? No, I removed it. Okay. 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 So this is the we have to know that we are over the tensor tympani tendon and we are we are not, we are over the GSPN, we are not over the facial now. So sometimes retracting the dura also becomes, I've had cases where the dura, revision case dura was exposed at this area. So there is a bleeding also, some dural vessel will bleed. So in a revision cholestoma, so you will have to just bipolar it. Don't puncture the dura again here. So see, this is the GSPN which is going here. So again, now if you ask me which is facial, which is GSPN, I without hesitation what I do is once I identify the cochleoform process, I just go anterior to that and cut it, because anterior to that cannot be
identify the weak end.
Yeah.
Then we know the exact
Curate coding. Sir?
When you're cutting the GSPN blindly,
Yes, sir.
if you identify the turning point of the
I'll do that, sir.
that cuts, no, then we are sure that you are not cutting the.
Hold the bone, please. Yeah, we identify the V band. All the muscle. See here, muscle in the canal. So sometimes the GSPN. See here is the V band actually. See, this is the V band here. This is a V band here. Give me small. This is a V band here. See here. This is the, see how it is closing close to the dura. This is a GSPN which is going here. Okay. So drill code badi. Drill a bit.
The area of interest is middle cranial fossa approach also.
Yeah, from when you're looking from above,
Is the area.
GSPN is one of the landmark in a simple middle cranial fossa approach. See, the GSPN, that is what they say, no? It goes so close to the dura. See here, there is the anterior to that. I know where is the V band. I even know where is the cochleoform process was here. So anterior to that is the GSPN. Just curate it, identify, not be in a hurry. Centering on.
So can you identify LSPN also?
LSPN.
Cutting the GSPN, LSPN.
Yeah, it is also supposed to run here, but honestly, I have not identified, sir.
So in the unrecovered Bell's palsy, okay.
Yes, sir.
That means they say that there is edema, persistent edema in the labyrinthine segment.
Yes, sir.
So if at all we have to do patient of decompression, we have to decompress proximal to the GSP.
Proximal, okay.
What is your message?
So labyrinthine segment decompression, honestly, I have not done. I have sacrificed the labyrinthine segment, but because Bell's palsy, I don't know, most of them have recovered. I've never
recovered.
So very difficult to.
Traumatic.
Traumatic palsy, I have definitely done till the first genu in my experience.
So they say the Schimmel's test. If the hearing is there,
yes, sir.
Then it is distal to the GSP. The GSP is intact.
Yes, sir.
So the facial injury is distal to GSP.
Sir, if it is hearing is good, hearing is good, then you would like to do it in middle cranial fossa approach. Again, personally, no, other than
Hearing is good.
Yeah.
If it is unrecovered Bell's palsy or are commanding the facial nerve rigidity.
Yes,
The
sir.
tumor there.
Yes, sir.
The tumor there, because
Old money.
hearing is there.
Yes, sir.
That means the injury is just a DSPN, and
Yes, sir.
you can do facial nerve decompression digital to you. But
Okay.
if hearing is not there, then you know that it is not. Then it's not mandatory to do decompression of the labyrinthine segment. Then you have to decide whether it's transmascular root or middle cranial.
Yeah.
Transmascular root, there is a good intra labyrinthine and based on not.
Mhm.
The subtractive method is only.
So if at all I have to do labyrinthine segment, I'll have to do like this only. The transmastered route only is what
Yeah.
I will do. I would like to go here,
Yeah.
identify the ample of.
Because again, middle cranial was approach means we have asked the neurologist some friends and they may
Yeah.
to do it.
Middle cranial fossa, that's a problem. We don't have much experience other than maybe GSPN we can identify. During my 1 year of stay in group, I only saw one middle cranial fossa approach.
One.
That too for a facial hemangioma involving the first genu. Prof did, and he is also not comfortable with middle cranial fossa approach. So I think basically one difficult to become an expert in all the approaches. So what is this? So drill kudi. Yeah. So then time to cut it. Give me, because now what we are going to do, the whole idea of cutting this, identifying and cutting is basically to reroute the facial nerve posteriorly. Okay. Give me. I did for one. Yes, sir. Yes, sir.
The facial nerve?
Not the facial nerve, sir. This GSPN here. This is the first genu here. Okay.
Center, please. Very important step.
Round knife pudi. Little hard. Give me curate. Again here one should be careful about the dura, how close it is a dura and the facial nerve. Okay. Okay. See here. You see this? See this posterior rerouting.
Yeah.
I have done. I also have experience of doing this in live in Petersburg cholestoma in a young boy. So this is the posterior rerouting of the facial now, and you reroute it, and see this is the V that sir was asking about. This is a V. So posterior.
Yes.
ಕೊಡು ಒಂದು ನಿಮಿಷ. This is a GSPN curtain, the genu, first genu area. So
this genital ganglion is not that clear.
Here, sir, this bulge, this thickened area, the geniculate ganglions. Give me iris scissor. So we have rerouted the facial nerve posteriorly. Now see what happens when you reroute the facial nerve posteriorly. So what we do is we fix it to the, again with the fibrin glue, to the posterior fossa dura like this. Okay, we fix it to the posterior fossa dura. So when we rerouted it anteriorly, you saw how we gave space over the bulb. When you rerouted it posteriorly, you see how much space you'll get. All this area where the facial nerve was going like this, when if it was, yeah, the facial nerve was, suppose if the facial nerve was here, you would reroute it, and without rerouting it would be take so much of problem. So impossible. So give me that silver foil of yours. Idradu suture material ಕೊಡಿ.
So now if you want to do closure, you need to do blind sac closure, isn't it?
Yeah. Now if you are done this much of drilling canal wall down, you have to do blind sac closure. We can allondu silver foil ittallappa. ಇದೆ ಕೊಡಿ ಕಟ್ ಮಾಡ್ತೀನಿ.
It's better to line with some facial data and then put the fat.
No, sir. No. Just fat. Fat is very useful. Hey, cut ma suck ma So I'll just protect it because you have taken effort to preserve it. Even in this slender, I mean, this facial nerve has been protected till now. So now, okay. So just fix it like this fibrin glue. That will make sure that you don't have any injury. Yeah, please. So this is protected here, sir. Facial now. So now, what is left? If you see here, cochlea is only left, okay, and the cochlear nerve is left. So we'll see now all this. If I remove this, so you have opened the dura. All you have is carotid here and posteriorly cerebellum, and that's all. So it gives, this is the widest exposure a modified transcochlear approach for a in a skull base. Yeah, not thin. I think it should be good enough. So yeah, now we'll do the cochlear drill out. So as I said, you can widen this inferior lip. Yes, sir, yes. Enlarged. Now is this okay, or you want further widening, sir? This is better. This is better. Yeah. So focus madana. So this is the cochlea here. Yeah. And we can actually yeah, we can see the modulus here. The modulus is the bone medial. We can even see some membrane here. Okay, we can see some membrane. Should be the osseous spiral lamina. Should be the osseous spiral lamina. Give me a curved pic, pa. Yeah. This no, we are already seeing, sir. See, this is the osseous spiral lamina. This is a scala tympani where you want to put the electrode, and this is a scala vestibuli, which is a superior canal, and which is a little smaller in shape. Okay, this is the scala tympani. Okay, this is the scala vestibuli. Okay. So we'll drill the basal turn of the cochlea. This is probably the tympanic plexus. I just drill out this. So as I said, we can open this inferior lip because if you drill here, I mean, I'm talking about for cochlear implantation, you may drill the basilar membrane. Drill here, you will not drill. Okay. So I'm just going to do a drill out. So just follow the basal turn of the cochlea. Just follow the basal turn of the cochlea. You see this membrane? And just now you know where is the carotid, so you don't have to worry. The basal turn. Yeah. Yeah, it can give me very small suction, something like 18 or 20. So the membrane like that is the resistance membrane. What you're seeing? This should be the basilar membrane, sir. Maybe one basilar and one resistor. This should be the base. This is our spiral lamina till here. From here, what is going probably here is one is of course you get the basilar, and when you get the resonance membrane, but I think one that hugs the basal turn lateral wall is actually the basilar, and actually this is the scala media. Here is a scala media in this duct. What I'll do is that is one for that, and then I'll drill the middle turn here. Apical turn you should drill under the cochleoform process. Yes, sir. We are done actually almost. See, this beautiful scala tympani is wide here,
Yeah.
and as it goes up, this is probably those nerves. You can see those black dots. Black dots. The same. Just then a modified transcochlear approach, as I said, colostomas and all, which are gone here under the petrous, you cannot preserve the cochlea. So ultimately, you will have to drill everything. So you reroute the nerve like this and drill the cochlea also. You be careful. If you put a endoscope and see, you will see superiorly there will be dura, posteriorly there will be dura, anteriorly there will be carotid, and it will be under surface of cochlea which will be drilled. See this turn coil, just coiling here like this. Can you give me a smaller drill? This remnant of that stapes, I think. Totally the. So there's no way you can drill this keeping the facial nerve in the canal. I mean, you can just drill probably the basal turn. See here, vestibuli. Just check where is the ಸಣ್ಣದು ಒಂದು ಡ್ರಿಲ್ ಕೊಡ್ತೀರಾ? The one size ಸಣ್ಣದು ಕೊಡ್ತೀಯಾ?
Pass a small rolling.
Yeah, rolling.
Come out. Actually, the head on here is the patient. Upper one is the patient stand is not the patient middle stand. It is which you have seen. The chair in the end.
Even this cochlear duct will open into the your what do you call into that vestibule. That's one of the opening into the vestibule. We are all very close to the vestibule. If you notice, the medial wall of the vestibule. Sorry,
Yeah.
close to the medial wall of the. I think this is apical turn now. So this is a canal of few years. I mean, sorry, the tensor tympani.
Is it outside the?
This one, sir. This one is the apical turn. Give me cord pick. Give me curate.
On your right is the patient turn. On your left is the middle turn. Typical turn technique. Above is wide.
Yeah, this one, sir. This one. This is apical turn. This is the middle turn. This is the middle turn. There are two turns here. There's a bone here. Okay. I'll show you. There's a bone here. This is the. You have proline or waist thread denied, yeah? Drill ಕೊಡಿ ಸಣ್ಣದು. No, ಸಣ್ಣದು. ಸಣ್ಣದು ಡ್ರಿಲ್ ಇದೆಯಾ? ಅದು ಇದಕ್ಕಿಂತ ಸಣ್ಣದು. Smallest, yeah, that one I think. Yeah, let's put it on.
See how close is the carotid artery. Okay. Give me that proline, boss. Okay. Proline ಏನಾದ್ರು ಇದೆಯಾ? ಥ್ರೆಡ್ ಏನಾದ್ರು ಒಂದು ಥ್ರೆಡ್ ಕೊಟ್ರೆ ನೋಡೋಣ ಎಲ್ಲಿ ಬರುತ್ತೆ. ಯೂಸ್ಡ್ ಸಿಲ್ಕ್ ಅಥವಾ ಏನಾದ್ರು ಸಿಲ್ಕ್ ಅಥವಾ ಕ್ಯಾಟ್ಗಟ್ಟೆ ಯೂಸ್ ಎಥಿಲಾನ್.
Can you use the dumping plant? Just to see how it can come from.
Can you?
The center one is the modular.
Yeah, center is a modular. You can clearly see the membrane duct. Right. ಇದು ಕಷ್ಟ ಎಥಿಲಾನ್ ಇಲ್ಲ ಅಂದ್ರೆ ಇದು ಕೊಡು, ಸ್ಟ್ರೈಟ್ ಫೋರ್ಸೆಪ್ಸ್ ಕೊಡು, ಸ್ಟ್ರೈಟ್ ಫೋರ್ಸೆಪ್ಸ್, lumbar forceps. Man, the graph forceps was there, no? Not this man, one more was there, Udadu. It's also okay, but I don't think it will be possible to push this. Because it will not, it will just open up, those threads will open up here. Give me a cord knife, sorry, cord pick. But anyways, what we can tell is when you push an electrode like this, it will hug the.
There? You are there?
Yeah. You want to put electrode and show? I will not go further, not possible. Very soft.
There with the dumping plant helpful now?
Input.
Not sure. Just for the sake of demonstration. It will go inside, isn't it? It will not go anywhere. We can try. We can try actually. We can do.
See, this is the osseous spiral lamina.
Which one?
This one, sir. This one till here.
Okay.
And from here, this bone, I think this is the spiral lamina. This is the osseous spiral lamina. This one. This is the superior vestibular duct, and now is the scala tympani. Here you have attached.
So we have another 15 minutes. Huh?
Yes, sir. This is how you hold, right? This is a flange. Electrode, huh? I understand.
Yes, if you are comfortable, you can.
Yeah, you can.
Yes, yes. Face
This
upwards. Right flange to be faced downwards.
like this, right?
And upward. The other direction towards the lateral canal.
Okay.
In a turn 90-degree turn. Yes.
Like this.
Yes.
Yeah. Now you just hold this and pull this, is it?
Push, push.
Not done this.
Maybe kind of hold it with the left hand, sir. The forceps interchange.
Little tricky.
No, I'm not done.
Table right and left hand and then
This one,
You can hold the tubing behind and then electrode.
this one also.
Yes, and you can push it.
Very thin. No, there's no bone. It gives away. Can you pull it out?
No. Yes, we push back.
now if we are inserting implant like this, it will be for a single cavity. So contact enamel is cochlea.
Left hand.
It will be like this.
In the net cord.
Where
Yes.
partitions are not there, incomplete partitions. Isn't it?
Yes.
Right.
Yes, sir.
Something like incomplete partition.
Because there is this thing above, it just comes off the electrode.
Yeah, there is nothing.
No bone to support it.
Okay.
Maybe further I'll push it. Now I can just try once. Is it focus there?
It's focus.
Other hand stiff. Sorry, it comes out.
Where it comes out.
Comes out. Maybe you can try once more.
Yeah.
Yes.
No problem, sir.
I don't want to break it. You want the mic?
No problem.
I think we may damage the implant.
Just put it back.
I think it's okay. Only the apical term you can show us.
Just try once.
No, it's not. It's jams.
And I thought,
Electrode is jammed.
okay.
The work is got it done.
No, I think it is not
Yeah.
going in. The implant
Yeah.
is going to very difficult on those.
Yeah.
Okay, sir.
Yeah, magnification is okay. Not go right. I think it's become soft. Yeah, it's okay.
With the curved peak only,
ಅದೊಂದು ವೈರ್ ಇತ್ತಲ್ಲ ಕೊಡಿಯದೆ ಮೆಟಲ್ ವೈರ್
you remove those soft tissues
ಎಸ್ ಸರ್
and you can, with the curved peak only, it shows.
give that wire, somebody gave me that metal wire or something. Had yeah, there's a stillet. Okay. ಒಂದು ನಿಮಿಷ remove the epithelium. Yeah. No, we cannot turn anything here, so we'll better remove the epithelium and rid of everything. Give me that suction, please. This thin wire, huh? Okay. Whatever wire, it will not go there, yeah. Do it, rebound. Yeah, we are wasting time. Makes no sense. Anyway, we identified scala tympani. We have to identify that, it should go there. It's curving here. Drill. So, see here, if I remove this is where the thing is turning here. Okay, the basal turn is turning. Just keep it like this, ma. We'll I remove the soft tissue. ಸ್ವಲ್ಪ ಹಾಕ್ಬೇಕು saline. Okay. So we'll remove the soft tissue. Give me that curd pick or curd pick or sickle knife. Curd pick. So this is the basal turn. This is the apical turn here. You can see this. This is actually the membrane, and this is the osseous spiral lamina. And you can see the nerve endings, the dog spots in the modulus. All this in the circumference of the modulus. We have the nerves, the nerve bodies. Still more magnify, sir. Becomes blurred a bit. Yeah, now, sir. Okay. So this is the basal turn here, and this is the thing. Now this will be the apical turn. You can see here. So
the extreme left is apical turn.
This one, sir. Yeah. So this is, you can see nicely the osseous spiral lamina, and you can see how this is the modulus.
Yeah.
This is the modulus. Looks very beautiful also.
There the cochlear nerve. Now can we show the show the cochlear nerve stop? It is
Going down, sir.
Yeah, no. Cochlear nerve stop.
This one?
No, from here. Cochlear nerve stops which you had shown the cochlear nerve in the internal artery.
Yeah.
So then we can see the continuity with the low power. And show with the low power. One more. Yeah. Now we can see
basically it comes from the modulus. So give me that drill kodo. Or drill off this transverse crest. Pedal ಇದೆ. Sorry. The focus is not there. Okay.
Yeah.
Drill kodi. The anterior posterior moving. No? Okay, sir. Now?
Yeah.
Now let's see the down focus is not okay.
Because high focus, no?
Reduce it.
Yeah, it's clear.
Hold this. Reduce it. Now it's better. Light is correct, huh?
Yeah.
Yeah. So we have seen the basal, middle, and apical turn. It's all clear.
And from modulus, the
cochlear now. Give me a curd pick.
Ossicle knife. So this is, we already removed the facial. We had only the inferior vestibular now here. This also I will take it off. So what remains? See, give me Iris scissor, boss. ಸ್ವಲ್ಪ ದೊಡ್ಡ ಸೆಕ್ಷನ್ ಕೊಡ್ತೀರಾ? Okay. Clean this. Curate. Hold this. Drill ಕೊಡಿ. See, from the modulus, this is a bone. I can feel the bone, and you can see the cochlear now here.
Yeah.
Okay. Wash ಕೊಡಿ. Iris ಇದೆನಾ? Facial is already rerouted. You don't have to worry about that. Sheath of the facial. Give me a big drill. Sir, cochlear now is now clearly identified. Give me a curate. I'll just drill off this basal turn, leave no bone. It's like looking.
Diamond bar.
Diamond
bar.
Diamond bar ಕೊಡಿ, ಸ್ವಲ್ಪ ದೊಡ್ಡದು ಕೊಡಿ. Yeah, see here?
Yeah.
I can see from the modulus how the cochlear now arises. Okay. So give me a drill. Yeah. You don't need this now. Irrigate. Field.
You should not very sharp edges and all this, you know, all this
Yeah.
at the end of the
Probably can preserve this in a. We'll keep a museum. Iris is ಕೊಡಮ್ಮ. Take this. So what we are left is with only the modulus. Clean this, please.
You're on time.
Yes, sir. Just want to add one thing. See, now we have exposed the interlocustic meatus here, of course.
Yeah.
So now we're not going to. I mean, we'll not waste further time. What I'm saying is, see, now if I drill all around here, all that. So yeah, that's a facial now.
You will bore this area.
Yeah, no, sir. This is already open.
Yeah.
If I drill all this area under that, especially in a cholestoma, sometimes it will be eroded. You will get dura.
Yeah.
So there will be nothing but dura between you and and cerebellum. So posterior also, see, we have cerebellum. See, when we did a translab, this is the amount of space we got.
Yeah.
When we did a modified transcochlear, you can obviously cut all this. You'll get space till here. Okay, space till here and a control over the carotid. See, if you're doing a lesion which is going to the brainstem, you need a control over the vertebral basilar artery and all those things. So control over the carotid. So this is the whole idea why we did.
So definitely in a petrous bone cholestoma, you may have to do this much drilling sometimes. I mean, depending on the cholestoma. So this is nothing but the bone there.
Because the efficient structures, when the efficient structures are being just an hour of the mentor could have even been the purpose, even basically structures inside, and we need to have a culture. So the Vietnam will be removed, but it was intact. Chemical retina, it was there, and there were cochlea, it was there.
Help up. You know? Yeah, it is apex only. Anything under the cochlea is petrous apex only. Wash. Wash.
So that's why I say it's a temporal bone, out of 206 bones in the body, when you have 270 bones, one bone gets through, and we have only 206 bones.
Wash ಮಾಡಿ
206 bones, the whole complex of body consists.
all petrous apex.
These are little parts, totally different.
So you are seeing the dura there. I'm seeing the dura there.
Yeah.
So that is the dead end. So beyond that is
Yeah. You know, the medical are only what they will do. It's 5 hours.
wash.
Okay, we are there, I'm working with them. We are there. But yesterday, we all got hope, monitoring, after doing the dissection.
Yeah.
Second day, we now know that there are so many things to have. And according to me, one lifetime is not enough to master it.
Yeah.
And I thank
Sure,
Dr. Uday for
Thank you, sir.
excellent demonstration. And you really did your best to show the intricate anatomy.
Yes,
With the, even though there were limitations with the post available,
yes, sir.
still we could get three-dimensional orientation of majority of the lateral skull. If not everything, majority of the lateral skull surgery, you have shown in excellent way, and you have shared your valuable experience with us.
Yes, sir.
And we are very thankful for that, and very thankful.
Thank you, sir. Thank you for the opportunity and also the audience who could listen to me patiently
Yeah.
and made some good friends. I mean, at least few people I got to know yesterday's event, and Shreyas also for. And thanks for the facilities, sir, which are here. I mean, that is also important, and for the opportunity. Thank you, sir. And the staff of Ments
Yeah.
have been assisting so well and patient. So I think we'll wind it up here, sir.
Yeah,
I mean,
you are exactly on time.
yes, sir. Thank you, sir.
So we'll break for lunch, and before
Don't
lunch we
worry.
have a group photograph.
Yes, sir.
After that we'll have
Give me that vascular forceps.
Come back by 1:45, so that you'll have more time to start dissecting. You can go early. Okay, there are so many procedures now. I think difficult to name also. So let me try. Okay, trans labyrinth and
So we can see the V of that Janun. See, the nerve is nicely preserved. I mean, see.
Then jugular, okay, then facial rerouting, and then cochlear glove, and if temporal bone is still remaining, you can take them home. Okay, thank you very much. Okay.
Thank you, sir. Thank you.
We all know. I'm very happy that we all learned and shared our.
Thank you, sir. Thank you so much.
Thank you. Please join us.
Yes, sir.
Thank you, Odisha.
Thank you. Thank you, Maidana. Thank you, Maidana.
Thank you.
Thank you, brother. Some more.
ಅದು ಒಂದ್ಸಲಿ ಫೋನ್ ಪೂರವರೆಗೂ ಬೇಸಿಕ್ you sit with the phone, no, it will drag you into that section zone. Drag you and then take it. It's very good. Came out well. I was not expecting it. Yeah. It's a little hard bone, it came out. So planning now. That's all. I've done enough to decision. Came out well. It's all everything. But I don't. This was there. Now the phone is finally. Yes, sir.